A very good afternoon to all of you across the country who are joining us. This is Dr. Nitin Yashas on behalf of the St. John's Medical College Alumni Association, welcoming you all to this academic feast over the weekend just before the Football World Cup final tomorrow evening. So before the Grand World Cup final, where probably everyone is rooting for Messi, the Alumni Association is proud to bring to you academic fest. Before we move forward with today's academic session, it's my privilege to introduce Dr. Anthony Robert, consultant pediatric surgeon, a teacher par excellence and president of the St. John's Medical College Alumni Association, to address you all with really the aim with which we are starting off this virtual CME program. Dr.
Good
Robert.
afternoon, dear Johnites. Good afternoon, dear Johnites, spread across the country in all our rural centers. As Nitin has so eloquently put it, we timed it, I think, really well before the football final. The genesis of this, of this idea, basically came about when Sister Dr. Blanche, when she took over, and I was meeting her, and she said one of the problems they faced when they're working in the periphery is the ability to collect CME points and also to learn new stuff which is there in the different fields for common issues. So the objectives of this are twofold. One, of course, is knowledge, but very selfishly to put it, I think getting the points is also important because it's really something that the regulatory authorities will push on us. And the Alumni Association is happy to help in this way. This is the first time that we're able to do this with CME points. I'm really glad that a big plethora of talented speakers, people who've worked in the rural sector, are here to share their knowledge and know-how over the next 2 days. We are extremely talented, some of them in John, some of them outside John's. And I'm really proud and grateful to my team, especially Nitin Yashas and his energy, and Prithvi Dasri, Sister Sophia Anthony, who's also very, very essential in this, and of course Cyril, who's our glue. So without much ado, I wish you guys luck, have fun, and we hope to do this one more time next year so that the points keep coming into the meter. God bless.
Yeah. So, Dr. Robert, our first speaker will be Dr. Kurian, who will be joining us shortly in 5 minutes. And of course, we are seeing him join in as of now. Yeah, yes, Dr. Kurian is there. Um, Dr. Kurian, thank you so much for joining us. Dr. Kurian is a consultant neurologist at Indo-American Hospital in Kerala. He did his MD
Hi,
internal
Nitin.
medicine from, he did his
Am I audible?
MD. Yes, yes, you're audible.
Yeah, I cannot.
Yes, you are audible.
Yeah. So Dr. Kurian, to introduce to all of you, did his MD internal medicine from St. John's Medical College. He then did his DM neurology also from St. John's Medical College. Someone who is very, very meticulous, who is very, very passionate about teaching and now doing wonderful work in neurology in Kerala. And no better person to teach a topic which can be a headache for most of us, and that is really on how to approach headache as such. So I would just guide Dr. Kurian on how to load his
I cannot.
slides as of now. Dr. Kurian, are you able to hear us?
Nitin, I can hear anything. Yeah, really. So what to do? I cannot hear anything. Okay.
Right. We are waiting for Dr. Kurian to upload his slides as such, and we will be starting. Just few rules. This is a KMC accredited event. So there are two CME points which are there for the event as such. And you're all requested to please type in your name, the batch if you're from St. John's, which batch you're from, and which hospital you're working in currently as such, so that this can be used as proof of attendance when submitting for your accreditation points. We have almost 100 people joining us across the country as of now. So that's a wonderful thing. We are just waiting. There are a few people who have messaged to just wait for a few of them to join in. So we will be starting the session in the next 5 minutes as such. Dr. Kudian, are you ready?
Nitin, please message me when I have to start because I cannot hear anything. So once you tell me, I will start. Okay. So, good afternoon, everyone. So, it is wonderful to be here once again with people from St. John's. So, I thank Dr. Nathan Yeses and the entire team from the alumni for the opportunity to present in this forum. It is going to be a slightly strange presentation because I don't have a handle on my slides. So, the able Dr. Nathan Yeses will take over for that for me. So, approach to headache. Within the next slide, please. Yeah. So headache is one of the most common outpatient complaints. You can easily say that headache is the brain and the bread and butter of any aspiring neurologist. For that matter, if you properly manage headache, we all used to say that your patient outpatient consultation only will increase. So whenever you see a patient with headache, the most common thing that should come up in your mind is that the most common diagnosis of headache is migraine. 1% of general population has chronic migraine and 12% of general population has migraine. 50% of the world's population is supposed to have experienced at least one migraine attack in their lifetime. So you all are aware of the pain sensitive cranial structures. So I'll not go into detail. Next slide. So whenever you see a patient with headache, what you are supposed to identify is whether this is a primary headache disorder or whether it is a secondary headache disorder. Next. Primary headache disorder. So always understand that it will be stereotyped. The patients will come to you with an episodic patterned headache. The same type of headache recurs again and again. And also they will have pain-free intervals in between. All of you should download the ICHD criteria. I will post it in the St. John's Academics group. So the primary headaches are very clearly defined and it's easy to diagnose. And even if it does not fit the criteria, always remember that the similar type of headache a patient has recurrently with in between pain-free intervals, you always think of a primary headache. But in your practice, always exclude a secondary cause of headache. Secondary causes can vary from very mild causes like sinusitis to serious life-threatening events like subarachnoid hemorrhage. Next. Nathan, next. So, how to identify whether the headache is primary versus secondary? How to not miss upon a serious secondary headache. So you can use the mnemonic SNOOP. So S stands for a patient who has got systemic symptoms like fever. So you have a patient with meningitis who is coming to you with high grade fever and neck stiffness. You don't think of a primary headache. Always be careful when you are dealing with patients who have got systemic diseases, like an immunocompromised patient, like an HIV positive individual, a transplant patient, a patient who has received chemotherapy, a patient in whom diabetes is uncontrolled. All of these situations, you should search for a secondary cause. The N stands for a patient with underlying malignancy. And also, if on clinical examination you have neurological deficit, which can even be an altered consciousness or weakness of one limb. So, any patient with a focal neurological deficit, always you should search for a secondary cause. The third thing is O, which stands for if the onset is sudden or abrupt, like in a patient who comes to you with a thunderclap headache. That is when the headache reaches maximum severity in a time period of 30 seconds. Elderly individuals, when they are aged more than 50 years, when they come with a new onset headache, don't make a easy diagnosis of primary headache. Then P stands for a recent change in pattern of headache. If the patient has got a change in headache with the position, if the headache is precipitated by Valsalva maneuver or situations which can simulate a Valsalva like coughing, sneezing, exercise, etc. Any patient with a new onset headache, or for that matter, a chronic headache, always try to examine for papilledema. So, in these situations, you have to investigate the patient for a secondary cause. Next slide. Based on location of pain, you can identify some of the primary headaches. So, if a patient has got a band-like sensation involving the head, bilateral frontal region, and in that situation, you think of a tension type headache. Migraine headaches are usually unilateral. They can progress to involve the entire head. It can even be bilateral in some situations. The third thing is a patient with a cluster headache. Cluster headaches are one of the most common types of trigeminal autonomic cephalalgias, where patients come with severe unilateral short-lasting headaches and which are associated with autonomic symptoms like redness of the eye, lacrimation, excessive nasal discharge, periorbital puffiness. In those situations, think of a diagnosis of cluster headache. If a elderly patient comes with elevated ESR and unilateral severe headache, and the pain is along the distribution of an artery, think of temporal arteritis. Of course, you all see patients with regional pain due to sinusitis, cervical spondylosis, etc. And patients can have pain along the distribution of the trigeminal nerve. It can be in the V1 distribution, V2 distribution, or V3 distribution. In that situation, think of a trigeminal neuralgia. The duration of headache is another important thing that can help you in localizing. So this is not the exact criteria. Usually we say that more than 4 hours for migraine. For remembering, you can keep to the rule of 3. Migraine 3 hours to 30 days. Tension headache can last from 30 minutes to even years. Patients come to you with, they have for the past 1 year, I am having a band-like sensation. Cluster headache, like I mentioned, a unilateral severe headache, which is more common in males and usually comes on at night. Patients can have 2 to 3 attacks up to a day. That is up from 30 minutes to 3 hours. Also remember that cluster headache is one of the headaches with periodicity. Patients can have headache for approximately 1 month, and after that the headache goes away. Next year it will recur in the same time. Paroxysmal hemicrania and SUNCT are two of the other primary headaches, with paroxysmal hemicrania lasting 3 to 30 minutes and SUNCT lasting 3 seconds. Patients with chronic headache, when we say it is when the headache is more than 3 months, and if there's a migraine headache which is lasting for more than 3 days, it is called status migrainosus. Next slide. Next slide. So, what is a thunderclap headache? Any patient comes to you with a sudden severe headache, which majority of the time they describe as the most severe headache of their life, which reaches its peak intensity within 30 seconds. This is a secondary headache. And these are the multiple causes of thunderclap headache, the most common being a subarachnoid hemorrhage. Patients with a CVT, even meningitis can present with thunderclap headache. The patient requires urgent imaging. Don't keep such a patient under your care for very long time. This is a patient who requires early referral, early intervention, and your referral might even be life saving, because and if you pick up an aneurysm at the early point, a coiling of the aneurysm can be life saving in such a patient. Next slide. Always inquire for stressors. So, especially patients with a tension type headache, vascular headache, these patients have significant stressors. But always keep in your mind that the stressor should not be your first diagnosis. We always used to hate postgraduates or residents who used to say that the patient's diagnosis is stress when they cannot locate the diagnosis properly. Any patient who is suffering from migraine, more than 15 days a month and all, if you have migraine headache, you are expected to have stressors. But that does not mean that the stress is the reason for the patient's headache. Always inquire for medication history. Analgesic use, if patient is abusing analgesics, it can lead on to medication overuse headaches. Patients with contraceptive use, pregnant ladies, all of these people are prone for prothrombotic episodes like a cerebral venous sinus thrombosis. Essential oil abuse is something that we have recently come across a lot, and we see that patients who are using eucalyptus oil, Vicks, Amardanjan, these kind of things, whatever medicine you give, the prophylactics don't work. They have a chronification of the headache, and the patients have less response to even abortive or prophylactic treatment. Always inquire for history of trauma. This is important in secondary headache. The patient can have an intracranial hemorrhage. Many a time patients might not even mention to you the history of trauma. And also keep in mind that some patients can have a new onset migraine or a cluster headache after an episode of trauma. Next slide. Postural variation, like I mentioned earlier, is one of the pointers towards a secondary headache. So you can have one very common thing that you will come across is a patient who has undergone a surgery recently. They say that when I am sitting up, I am having severe headache. If I lie down, the headache resolves completely. So this is an orthostatic headache, and this is due to low CSF pressure. Raised ICP, as in patients with meningitis or a intracranial space occupying lesion, these patients can have a headache which is more on lying down. Next. Next slide. So this is what I mentioned already. A patient with orthostatic headache due to a CSF leak, the patient will have more headache on standing, and raised ICP headache is increased while recumbent. But what we see, another thing is that patients who develop this orthostatic headache after a lumbar puncture. But you can have patients who have been involved in road traffic accidents. They don't, even if they have a CSF leak, many a time they don't develop this orthostatic headache. I will not go into the reasons for that here. We all have a beautiful classification of headache disorders, especially for the primary headache from the International Classification of Headache Disorders, the Headache Society. The latest one right now is the ICHD-3. So this is something that all of you should have handy. You can refer, confirm your diagnosis, and treat appropriately. Next slide. So current one, as I said, is ICHD-3. Next. So Mr. Jan Olsen is one of the legendary neurologists who is currently heading the ICHD-3 committee. Next slide. Next. Next slide. So the ICHD-3 classification, the part 1 is the primary headache, part 2 secondary headache. Nitin, next slide. Next slide. So coming to the primary headaches, which will be the focus of today's discussion. The primary headache disorders, these main ones are, like I mentioned, migraine, tension type headache, a trigeminal autonomic cephalalgia, and the other primary headache disorders. This is what you will most commonly see in your OPD practice, and this is what you are expected to manage properly. Next slide. So coming to a case scenario, a 30-year-old lady presented with history of headache for the past 10 years. The patient has got a right-sided throbbing headache of varying severity. She prefers to stay alone with lights turned off during the attacks. Along with attacks, she gets severe vomiting episodes. Also, if somebody speaks loudly to her, she gets irritated. During menstrual cycles, she gets headache. And travel and missing food also triggers headache. So I have highlighted the salient points here. So here you can have a patient who has got a unilateral right-sided headache. She has photophobia and phonophobia, and there is associated vomiting. And she has some triggers like menstrual cycles, travel, and missing food. So this is a patient with a classical migraine. Next slide. Migraine is the king of all headaches, and it is the most common cause of headache presenting to the outpatient department. Next slide. So this is divided into migraine without aura, migraine with aura, which is otherwise called classical migraine, and you have a chronic migraine when you have more than 14 days of a month the patient has attack or daily headache attacks. So this is the criteria for diagnosing migraine. So a patient who should have a minimum of 5 attacks in the past, that is in patients without aura. If there is a patient with aura, 2 attacks is enough to make a diagnosis of migraine. So the patient should have a unilateral headache, which is pulsating in quality. Migraine attacks usually are moderate to severe pain. You don't have a very mild headache with migraine. And any aggravation of physical activity. So if the migraine patient will sit in one corner and avoid moving around. Whereas you have a patient with cluster headache who will be running around everywhere and coming to the nursing station asking for pain medications. The attack lasts 4 to 72 hours. So you don't have a patient with a 10 minutes attack of migraine. The headache attacks are usually more than 4 hours and can last up to 72 hours. And during headache, at least one of the following should be there: nausea or vomiting, and photophobia and phonophobia. And you should rule out other secondary causes. That is one criteria in all primary headaches. Next slide. So like I mentioned, there's migraine with aura. Aura can be in different forms. Some patients will say that I see some lines in front of my eye. I see some light in front of my eye. So it can be visual, sensory, motor. You can have mild weakness or numbness involving one side of the body, which is followed by headache. Usually with onset of headache, the aura goes away. So this is a patient with a classical migraine. Migraine patients usually have other associated illnesses. They will have lots of gastric complaints, lot of body pain. Some patients have got, with the vestibular migraine, have an imbalance while walking. They will often get misdiagnosed as BPPV. There can be, the patients will have associated depression and anxiety. So don't be in a hurry to make them a patient with a mood disorder, because their primary cause of the disease is a migraine itself. Next slide. So, how to treat migraine? Lifestyle modification, acute treatment, and prophylactic treatment. Lifestyle modification is the most important thing. So, like I mentioned, the migraine patient has got triggers. Next slide. So if a patient, a person who is prone to skipping meals, reduced sleep, if I go in sunlight, I usually get migraine. Menstruation is one of the triggers we have difficulty in avoiding. And patients with migraine, we often see that if they are put on oral contraceptive pills, there is significant worsening. And we also see that there is a significantly increased prevalence of CVT in migraineurs who are put on oral contraceptive pills. Chocolates, red wine. I'm sure that there are many among your group who are people who are suffering from migraine. For acute treatment of migraine, we have multiple agents. Most simple is a paracetamol tablet. You have naproxen. You often get a combination of naproxen plus domperidone. I will mention brand so that it is easy for you to use. Naxdom is one commonly used medication which is comes in dosages of 250 mg plus 10. That is a naproxen plus domstat. I usually avoid ibuprofen. Paracetamol and naproxen give me good relief. And in selected patients, you can use triptans. Avoid triptans in patients who are prone for medication abuse, NSAID abuse, and also avoid patients with a coronary artery disease, stroke. Avoid triptans. Treatment of acute migraine, if it is not settling with these abortive treatments, when a patient comes with status migrainosus for your casualty, you can use IV steroids, IV valproate, injection prochlorperazine, which is Temetil, IM injection, 12.5 mg you can use. You can even use combination strategies in patients with a severe migraine, like sumatriptan with naproxen. One example is headset tablet, which is commonly available. Next slide. Always be aware of medication overuse headache. You are prescribed naproxen to the patient, he will have relief, and then they will take daily naproxen and finally come with a headache which is very difficult to treat. So, more than 15 days a month, if a patient is using NSAIDs, then it is called medication overuse of headache. In a patient who has got more than 4 headache attacks like migraine in a month, you are supposed to start the patient on prophylaxis. Next slide. Pregnancy is often a difficult scenario. You cannot use any medication. You can use paracetamol. Lifestyle modification is the crux. You can use metaperinome or metoclopramide in selected cases. Prophylactic medications are also very difficult. We rarely use propranolol in some pregnant patients after explaining the risk. NSAID should be avoided after 32nd week of gestation because of the effect on patent ductus arteriosus. Sumatriptan avoid using in pregnancy, not only in second and third trimester. Avoid use of triptans in entirety. Next slide. Prophylactic treatment can be pharmacological or non-pharmacological. Next slide. So, appropriately given prophylaxis reduces disability. The patient is able to function better, and also you don't need to use abortive medications too much. Next slide. So, like I mentioned already, more than 4 headache attacks like migraine in a month, then you are supposed to start the patient on prophylaxis. We have multiple agents which are available to be used as prophylaxis. Next slide. And we say that a migraine prophylaxis is successful when it reduces the migraine attack frequency by at least 50% within a period of 3 months. So what I want you to understand is that you start the patient on treatment. After 2 weeks, the headache is not better. You don't immediately change the medication. Persist with it. Go for the appropriate dosage. So these are the medications which you have available. Beta blockers. We use propranolol, start with 40 mg BD in a patient whom you are expecting that they might have some orthostatic symptoms, bradycardia and all. You can start even 40 mg at night and then go up to BD. You can go up to a maximum dose of 160 mg. Amitriptyline is another medication. Propranolol is the one with the least side effect, the best side effect profile. Amitriptyline you start with the 10 mg half tablet at night. When you read, you will find recommendations that start with the 10 mg at night, but the patient will go away to another doctor because of sedation, and we will lose one patient, and the treatment also won't be appropriate. You can go up to 25 mg, but they rarely tolerate that. I usually go up to 12.5 mg, 25 mg half tablet. More than that, the patients tolerate it less. Valproate is a wonderful drug, especially in very bad cases. Usually, we avoid in childbearing age group and females. We avoid valproate. Divalproate sodium, the action is faster, but it is a little costlier than valproic acid. Start with a dosage of 300 mg BD sodium valproate. Encorate Chrono is a good brand that you can use. Topiramate is a very useful drug, and also in patients with chronic migraine and medication overuse headache, you use topiramate. Start with 25 mg BD. You have to explain the side effect profile when you start topiramate. Flunarizine is one drug that I never use. I feel a lot of side effects. Patients develop weight gain. Some patients develop depression. Some patients develop Parkinsonism. It is a very good drug, you can use it. It's a personal choice that I don't use it because of the bad side effect profile. How will you choose the drug? So all of these things matter when you are selecting the appropriate prophylaxis. Next slide. So if a patient, migraine is a patient with hypertension, you can go for beta blocker, propranolol, like I mentioned. So does not have much effect on the blood pressure. Mainly the effect is on the heart rate, but you can still use it. Next slide. If you have patients who are obese, especially female patients, they will be very happy. They will bring all your relatives to see you. So you will lose 3-4 kg when you are starting the patient on topiramate. So next slide. A patient who is underweight, so a very emaciated patient and all, this is a patient who is ideal to be started on valproate or tricyclic antidepressant like amitriptyline. You can even use flunarizine in such patients because they will tolerate a little weight gain. Some patients are quite happy also. The patients who are insomniacs, anxiety, depressed patients, reduced sleep, you can use tricyclic antidepressant like amitriptyline. Flunarizine is also a good option for a short period. Don't give flunarizine unmonitored for long periods. Next slide. So patients who have got as associated cervical spondylosis, if it is a diabetic patient who has got a neuropathy, if you start a patient on amitriptyline, there will be an additional effect on the spondylosis and neuropathy. So you can kill two birds with one stone. Next slide. If your patient has got history of renal calculi, avoid topiramate. Always mention to the patient the risk of renal calculi. Ask them to hydrate well. If you are forced to use also, ask them to hydrate well. Patient who has got history of glaucoma, avoid topiramate and amitriptyline. So all topiramate, I have had two patients who have got developed precipitation of angle closure glaucoma. Amitriptyline because of its anticholinergic effect. High functioning individuals, topiramate, be a little cautious. Patients can have some memory issues. They will forget names. So can be a problem. So, a patient a person who is preparing for a 12th standard exam, don't start topiramate and destroy their life. A person who is having an associated mood disorder, you can go for valproate, which is an excellent mood stabilizer. Avoid beta blockers and flunarizine in patients who have got mood disorder because depression and other symptoms can worsen. In a patient who has got a migraine with epilepsy, migralepsy, even migraine episodes can lead on to epilepsy events. You can go for valproate or topiramate because they have good anti-epileptic properties. Next. So if a patient has got hepatic dysfunction, you cannot use, of course, valproate, you cannot use. Amitriptyline may be dangerous. Topiramate is a good choice in patients with hepatic dysfunction. In renal dysfunction, avoid topiramate. So in patient migraine with renal dysfunction, what you can go for is propranolol and valproate you can use safely. So this is a overview, whatever we discussed, all the other conditions. So it is just a repetition. Next slide. So start the appropriate drug, start at the lowest dose, explain the side effect profile to the patient and go up slowly. Next slide. Next slide. So 50% reduction in attack frequency is when you define that your treatment is successful. Next slide. So in a patient who has got severe headache attacks and who is not controlled with a single drug, you can go for combination therapies. Beta blocker, you can combine with a small dose of amitriptyline. Flunarizine, you can combine with the topiramate. Don't combine flunarizine with the beta blocker. The depression and all will be too much. You can use topiramate with amitriptyline. Topiramate and valproate together I have used. I have had one patient with CLD who developed hyperammonemia. It is one of the rare manifestations. I was lucky to have such a complication in my hand, so I thought I will mention it here. So all of these combinations are good and you can use. What the side effects will increase. Once the headache is well controlled for at least 6 months, then you can slowly taper and then, if possible, discontinue the drug. Next slide. So in chronic migraine, the ideal drug of choice is topiramate, and also in medication overuse headache. Cephali stimulation and Botox are just for your knowledge. It is for encourage you to take up neurology and join us in treating migraine successfully. Next slide. This is Cephali. So in your pregnant females and all, when you cannot use drugs, this is one thing that we use where you can stimulate the trigeminal nerve directly. Next slide. Next slide. So this is Botox. You inject at multiple sites a small amounts of Botox. Next slide. Coming to the side effect profile. So this is something that is very important and I want all of you to pay attention. So explain, I don't want to detail out the entire side effects. What I am going to discuss here are the side effects that what I observe in my practice. So patients who are put on amitriptyline, patients can have sedation and fatigue. That this is another thing. Last week, my patient who was put on amitriptyline, they were wrongly given amlodipine tablets. So I thought I will put just a project that, because you should, you may, especially if you are not routinely prescribing, always cross-check the patient's medications also. Sedation and fatigue. Patients can have dry mouth and dry eyes. Elderly people can have orthostatic symptoms, confusion. If you have a patient with prostatic hypertrophy, if you start amitriptyline, they can have urinary retention. Patients who are being started on propranolol, they can have fatigue. Always explain to them that don't stand up suddenly after lying down, because they can have orthostatic symptoms. You avoid propranolol in asthmatics, and in patients who have depression, avoid. Even though we say that patients, hypertensive patients, you can use propranolol. If a patient has got a decompensated heart failure, or if a patient has got heart block, avoid propranolol. Next slide. So topiramate, always counsel the patients that they are going to have some tingling or paresthesia of the hands and feet and around the lips, which is temporary and it will stop after you withdraw the drug. But some patients can have fatigue. Always tell them to take adequate hydration, because there is a chance of them developing renal calculi. Avoid in patients with renal calculi, and always document that if you develop redness of the eye, stop the medicine and come, because it is a medical legal issue if you start. Valproate, avoid in patients with the childbearing age group. If you start a 21-year-old young female on valproate and she develops 5 kg weight gain, she will curse you for your entire life. Patients can have hair loss, menstrual irregularities. Pancreatitis and thrombocytopenia are rare complications, but still you should be aware of those. Next slide. So coming to the second case scenario, Nitin, since I am not able to hear anything, I'll take 5 more minutes and finish my presentation. If there are any questions, you can message it to me and I will answer the questions here. That is the only thing that I feel is possible. So the second case scenario, I have a 40-year-old IT professional presenting with complaints of bifrontal headache every day at around 11 a.m. at her work it starts. The person describes it as a tight band-like feeling over the forehead. He's able to work with the for a headache, but his efficiency is reduced. There is no associated nausea or vomiting. Some photophobia is there. Next slide. So here you have a bilateral headache and there is a tight band-like sensation. It is not a very severe headache and there is no photophobia and phonophobia. Only photophobia is there. So this is a typical patient with the tension type headache. Some people use different names, and always remember when you are writing the diagnosis, many patients will not come back to you if you write tension type headache. They don't want the doctor to tell that I am a patient with tension. So something that we use is that vascular headache. So you can use one of these synonyms to maintain your practice. Next slide. So at least 10 attacks should be present to make a diagnosis, and the patients have a bilateral high headache. It is not when you have migraine, you have a throbbing or pulsating headache. Here you have a tightened feeling, you have mild to moderate in intensity. It is not aggravated by physical activity. No associated nausea or vomiting. Some patients can come with headaches lasting for days to weeks to months, and they will have tension type headache. Next slide. So infrequent is 1 per month, frequent is 1 to 14 days per month, and more than 15 days a month if you have headache, it is chronic headache, chronic tension type headache. Next slide. So there are multiple preventive treatments. So of course you ask them to have good sleep, manage the stress, involve in good exercises. And the pharmacological therapy, the best drug is amitriptyline. There is no doubt about it. If another option you have is dothapine, prothiodyne tablets are available. You can start with 25 mg and go up to 50 mg. Amitriptyline, like we mentioned, for migraine, you start with the 10 mg half tablet. You can go up to 12.5, or even you can go up to 25 mg, but always carefully counsel about the sedation and other side effects. You can use even SSRIs like escitalopram. Start with 5 mg tablets. So the best evidence for tension type headache, it is for amitriptyline. Dosilapine has got lesser sedation and a better effect in patients with the fibromyalgia and tension type headache. A chronic daily headache, this can be due to migraine or tension type headache, more than 15 days per month for at least 3 months. That is when you say that it is a patient with chronic daily headache. Patients can, even with secondary headache, patients can also come with chronic daily headache. Next slide. This is the last case scenario. So 60-year-old lady presents with history of persistent severe left-sided headache for past 1 year. Headache has progressively increased in severity. She complains of joint pains affecting the large joints and generalized body pain. She is depressed. There is no photophobia, phonophobia, vomiting. So what is the diagnosis? Next slide. One added point. So your routine blood investigation shows that the ESR is 70. All other investigations are normal. So is it chronic migraine, or is it a tension type headache? Is it a depressed lady who has come with a lot of somatic symptoms? So I want here all of you to remember the loop. So the disease patient has got systemic symptoms. There are associated neurological symptoms. The onset is after 50 years of age, and it is progressively worsening, and it is a persistent headache. So in an elderly lady who has come with a new onset headache with an elevated ESR, you don't make a diagnosis of migraine and send her home. She will come back to you with a vision loss. So this is a patient with temporal arthritis who should be treated with steroids and other steroid sparing agents. Maybe you can take up neurology and then start temporal arthritis treatment. Many patients with a secondary headache can present with chronic headache like giant cell arthritis, intracranial space occupying lesions, patients with the CVT, patients with the raised ICP. So you have young females with the obesity who come with headache and raised ICP. One common diagnosis is idiopathic intracranial hypertension or pseudotumor cerebri, where after the initial evaluation you treat with acetazolamide, the Diamox tablets. So headache is the most common outpatient disorder. Always be on the watch out for secondary headache. Choose the right drug for the right patient, and you will have a good practice, and you will be able to help a lot of your patients. So, four-legged animal in India, you don't call the four-legged animal as zebra, you call it as horse only. So, what I want to convey here is that common things are always common. So if you have a patient with a headache coming to your OPD, don't go for the most vague, rare diagnosis. Go for the common diagnosis. Identify secondary headache and try to do your best. Best of it.
Thank you so much, Kurian. I don't know if you're able to hear us. I think there's some internet lag from you, but that is the question that one of the bonders had messaged, which is when to do imaging for headache with CT or MRI.
Then whatever you are saying, you have to record it so that I can also hear it. Okay. If anybody has any doubts, you can message to me. So then I can answer. Any doubts about headache or other problems that you face regarding neurology in your routine OPD practice? When to do imaging for headache? So any patient who has got a secondary headache, so you go by the criteria. If you are suspecting a secondary headache, always do imaging. There is in primary headache also, in patients with a trigeminal autonomic cephalalgias, that is cluster headache, sunk, suna, paroxysmal hemicrania. These patients have a common association with pituitary disorders. So you should do imaging in those cases before you go for a diagnosis. And the criteria is always put a corollary saying that always rule out secondary causes. And in today's age of medical legal litigation, we can treat. If you are making a diagnosis of primary headache, treat for a period of 1 month, 1.5 months. If you are able to give significant relief, it is fine. Otherwise, always you can give the option of imaging to the patient. Nobody ever got sued for over investigating. It is always for under investigating. And no, always it is important to pick up other secondary causes. So if you have a doubt, always go for imaging, and then you can proceed with the treatment. Effect of Bluetooth and earbud with Android phones. See, this we had a very large spurt, worsening of already pre-existing migraineurs, especially children, young adults. With this COVID era, when they were using their laptops, mobiles a lot, significantly increased prevalence or worsening of the pre-existing migraine. So definitely it is there. Your lifestyle should be routine, and everything should be in measured appropriate amounts for a patient with migraine to have peace. Thank you.
Thank you so much, Dr. Kurian. This was indeed a task filled with headache. You're probably not hearing us still, but thank you so much for joining. It was a wonderful discussion on headache, and hopefully we don't have any more headache in dealing with headaches as such. Thank you so much. Right, we now come to Dr. Chaitanya. Chaitanya, can you hear us?
Yes, absolutely. Hi, Nathan.
Yeah, thank you, Chaitanya. Chaitanya is senior resident in the Department of Hematology at St. John's Medical College. More than that, he has been the best teacher for many years right now, a favorite among students and interns passing out, and no better than him to sort of tell us today about the hematological disorders which you face in rural OPD and rural practice as such. So the topic that we have asked Chaitanya to cover today is how do you approach pancytopenia when you see in the rural setting? What are the tests that you do? What are the tests in fact feasible to do? And then we'll have an interactive discussion and on some of the myths and beliefs that we encounter in rural areas. I would just like to remind all the people who have joined in that if you have indeed registered for the KMC CME accreditation points, please do type in your name, the batch if you're from St. John's, and also which hospital you are working in, because this will be the proof of attendance that would be submitted as such. So Chaitanya, all over to you. Please click on your slide to add it to the stream and you can go ahead with it.
Thank you.
Are you able to add it to the stream?
Is it coming now?
No, you just need to click on there, add to stream.
Okay.
Because I can see that you have uploaded it. You just need to click add to stream. Just hover your mouse on this thing and click on add to stream.
Yeah, I'm just hovering, but I'm only able to get edit name and remove from studio.
No, that is you're clicking the three dots there. Just don't click on it. Just hover on it
Yep.
and click add to stream.
I'm just hovering over it. I'm not able to get that to stream. I can change the slides, but I can't. Yeah, can you see it now?
I've added it. Can you change the slides? Just see if you can change the slides.
Yep, I
Yeah,
can change.
perfect,
Just
perfect. Yeah,
lovely.
yeah,
Thank you.
right. It's all yours.
Good afternoon, everybody. At the outset, I'd like to thank the St. John's Medical College Alumni Association and my dear friend Nitin for this kind invitation to talk on approach to pancytopenia. I think, first of all, the CME is a fantastic opportunity for all of us to first interact and also to shed some light on how to treat common disorders and not just anemia, thrombocytopenia, but in this particular case, pancytopenia. I think nowadays with patients becoming really so tech savvy, patients getting investigations done left, right, and center even before meeting a doctor, often you're confronted with the patient's investigations before you actually see the patient, right? And I'm sure all of us keep getting those either physically or online, a lot of reports without having physically seen the patient. So at the outset, always remember treat a patient, never his reports. So, what is the definition of pancytopenia? It is a decrease in all three hematological cell lines, that is the hemoglobin, total count, and platelet. Pancytopenia, as such, is not a disease itself, but it is a common pathway which is caused by various etiologies, which could be due to infections, genetic diseases, nutritional, which is so common in our country, autoimmune, which has now become again extremely common, and something that Nitin and I commonly deal with, which is malignancies. Pancytopenia, generally, if you look at it for ease of this talk, we divide it into two main causes. Either there's a problem with the production in the bone marrow, or the cells are being destroyed. If you look at a patient and you can figure out whether it's a production problem or the supply chain is being disrupted somewhere or being destroyed somewhere, you will never miss finding out a cause or etiology of pancytopenia. There have been some specific definitions for pancytopenia. A hemoglobin of less than 12 in a woman and 13 in a man. Platelets of less than 1.5 lakh. Again, some books do still mention that 1 lakh is now the cutoff. And any total count less than 4,000 or an absolute neutrophil count of less than 1,800. So you should have all three of these criteria to label a patient as pancytopenia. Before I come on how to evaluate a patient with pancytopenia, he may come to you, we should know what the causes of pancytopenia are. So what the mind doesn't know, the eyes won't see is a very common adage that we hear throughout our medical life, and it's so true. Unless you figure out what the causes are, it's very difficult to look for those particular signs or elicit history of those particular symptoms in a patient in front of you. As I said, there are two predominant causes of low cell count. One possibility is when there is decreased production, where the bone marrow, which is the epicenter for production, is damaged. So autoimmune diseases like systemic lupus erythematosus, rheumatoid arthritis, sarcoidosis, those are common causes. HLH, and I've put this up on the list because we're seeing a huge spurt in patients with HLH in the last 6 months. In fact, in the last 6 months, I think we've currently in St. John's itself seen 13 or 14 patients. This is something that you may not really come across because by the time they're investigated, they would have been referred to a higher center. But keep in mind that this is something triggered by a lot of tropical fevers, triggered by dengue, triggered by rickettsia, triggered by tuberculosis, or even HIV. And these are things that we are seeing commonly. Bone marrow failure syndromes like aplastic anemia is something that should be top on your mind when you see a patient who has severe pancytopenia, who's especially if they come with bleeding manifestations or an infection. PNH or paroxysmal nocturnal hemoglobinuria is a rare disease, but again to be kept in mind, especially when the patient comes to you with hematuria and symptoms of anemia, thrombocytopenia. I'll come to the evaluation later. In the era of drugs, both over-the-counter drugs as well as the amount of drugs that we generally prescribe, developing bone marrow failure secondary to cytotoxic drugs is something that we encounter very commonly. From a benign medication like an NSAID, such as a salicylic acid or even NSAID, all the way to the chemotherapy drugs that we deal with, any of them can have both idiosyncratic as well as dose-related suppression of the bone marrow. Why I mention this is that taking drug history is very important. Not only the drugs the patient is on, but if there are any drug-to-drug interactions. The other thing to remember in drugs, especially in our country, is the use of complementary medicines, especially Ayurveda, Siddha, homeopathy. You see a lot of practitioners use them. Always take a history of intake of complementary medicines because they have heavy metals, which can cause bone marrow suppression. Nutrition abnormalities, because we are still one of the biggest leaders in malnourishment all over the world. So B12 and folate deficiencies, malnutrition, especially in children, adults, especially those with excessive alcohol intake, and viral infections. Now, there's a whole plethora of viruses which can transiently suppress the bone marrow, dengue being one. But we also see it in Epstein-Barr, CMV, and COVID. We've had a few patients with post-COVID aplastic anemia who have come to us. So it's important that when you are suspecting that the pancytopenia is because of decreased production, you keep these things in mind. The other possibility where the bone marrow is directly damaged is with diseases of the bone marrow itself. Non-malignant like myelofibrosis, sometimes disseminated fungal infections, or even tuberculosis of the bone marrow can be seen. Leukemias, myeloproliferative neoplasms, chronic leukemias, myelodysplastic syndromes, multiple myeloma, or certain cancers which metastasize to the bone marrow. All of these can be responsible for pancytopenia. So this theoretically comes under decreased production as well. So you should remember that a lot of malignancies can present with pancytopenia. So if you have an elderly person who's presenting to you with pancytopenia, this is something to keep in mind. The second big spectrum of pancytopenia is increased destruction. As we all know, red blood cells, the white blood cells and platelets are constantly circulating, and they get destroyed in various parts of the body, especially the reticuloendothelial system, mainly the spleen. And there are some diseases where destruction of the cell components occur both within the blood vessels, that is called intravascular, or in the extravascular system, which is basically in the spleen. One of the biggest or best examples would be DIC, disseminated intravascular coagulation, especially when you have a patient with sepsis or sometimes acute promyelocytic leukemia. Or splenomegaly, when you have a patient who has a big spleen, the spleen causes a lot of sequestration of blood cells, and those blood cells senesce, that is age, and get destroyed. So various causes of splenomegaly like portal hypertension, certain autoimmune disorders, storage disorders, myelofibrosis, or malignancies. So don't worry about knowing every cause. Just know that pancytopenia can occur due to a bone marrow production problem or a peripheral destruction. And it's important to identify which, because the treatments are diametrically opposite. Coming to the crux is, how do you identify such patients? Please remember, pancytopenia can present asymptomatic if a patient comes to you with an annual health checkup or a randomly done CBC for something else, you find pancytopenia. Or they can come to you with a life-threatening emergency. I mentioned life-threatening emergency because some patients with leukemia or severe aplastic anemia can come with either a neutropenic fever. Because the white count is so low, they may come to you with severe sepsis, or the platelets are so low, they may come to you with life-threatening bleeds, gastrointestinal, intracerebral, or genitourinary. So you have a spectrum of patients who can present both benign as well as present in an acute emergency. Symptoms of anemia: shortness of breath, exertional palpitations, fatigue, or sometimes even anginal chest pain, mimicking anginal chest pain. Patient comes to you with classical angina and you find the patient has pallor. Very important to look out for. Leukopenia. So whenever the white cell count is low, especially the neutrophils, the ability to fight infections is severely curtailed. And patients can come to you with recurrent infections, throat ulcers. They can come to you with skin manifestations as well. And low platelet count classically presents with bruisability, petechiae, and a propensity to bleed. So if you have a patient who's come to you and you see oral mucosa blisters, classically blood blisters, or ecchymosis wherever the nurses are drawing blood, or they come to you with a history of melena, you should be very, very wary, because their platelet count is often less than 10,000. And some patients can come to you with severe life-threatening sepsis. Over the years, there was a very nice study which had been done over 15 years, which took a lot of articles and other smaller studies of patients with pancytopenia. And they found that the most critical part to evaluate pancytopenia was a good history. And this is one of the few places where we constantly stress that a history is key in patients with pancytopenia. The first is the duration of symptoms. How long has the patient been symptomatic? If it's a shorter duration, it's more likely to be a a disease such as aplastic or leukemia, which can suddenly creep up in a matter of days to weeks. Whereas a patient who has a long term history, a history over months or years, can sometimes occur because the spleen is getting bigger and bigger. The progression and the severity of the symptoms from small gum bleeds to melena is a dramatic jump because the platelet counts have fallen significantly. So it's important to catch patients, especially when they present early. Asking for symptoms of an autoimmune disease, especially in that particular age group between 20 to 40, females more than males, asking for joint pains, asking for oral ulcers, asking for dry eyes, or the classical photosensitive rash or vasculitic rash is extremely important because a lot of autoimmune diseases can cause bone marrow issues. Weight loss, night sweats, fever, chronic cough are all symptoms that you could be dealing with an underlying malignancy. And the old thought process was, malignancy generally seen in elderly people is no longer true. I think Nitin and I will both uh, definitely vouch for that. We've seen all types of malignancies at all particular ages. So never ever rule out a patient who presents with the classical B symptoms: weight loss, fever, night sweats. Very, very, very important for malignancy. Recent infections. A lot of our infections can cause bone marrow suppression, but very important is the drugs given for those medicines can also cause bone marrow suppression. As all of you know, the indiscriminate use of antibiotics has become a huge problem in our country. A lot of antibiotics suppress the bone marrow, right? And a lot of our patients have received indiscriminate antibiotics for the wrong duration and for the with the wrong dose, which can suppress the marrow. Medications, both allopathic and complementary medicines, as I mentioned earlier. History of chemotherapy or radiation, especially in patients who are cancer survivors, is important not just immediately but also in the long term. One big issue in our country, even in 2022, is nutrition. And especially in children and young adults, we see that poor nutrition, especially patients who have chronic diarrhea, can have multivitamin deficiencies, especially vitamin B12. They can have iron deficiency anemia, folic acid, multivitamin deficiency. So it's important to ask history of chronic diarrhea, history of weight loss and abdominal symptoms such as suggestive of acid peptic disease, because H. pylori can cause chronic gastritis leading to B12 deficiency. Ask for history of early satiety, abdominal bloating, dyspeptic symptoms, weight loss, or even previous history of GI surgeries leading to malabsorption. Always take a family history if any blood disorders in the family. Personal history, substance abuse, not only alcohol, but nowadays, of course, recreational drugs. Sexual history, sometimes, especially if you're dealing with HIV or rarely syphilis, but mainly HIV, hepatitis B, and hepatitis C can affect the bone. When you look at a patient or examine a patient, the BMI is important. A malnourished patients itself, the malnourishment itself can suppress the bone marrow because there is no food, there is not enough intake of nutrients to supply the bone marrow to produce cells. Also, when you see a patient who's emaciated, always consider a possible immunocompromised or malignant state. Examine for pallor, which tells you there's anemia. Petechiae and ecchymosis point towards thrombocytopenia. Oral ulcers, especially in neutropenic patients. The presence of icterus sort of narrows your diagnosis down that you could possibly be dealing with a destructive process. As I mentioned earlier, pancytopenia generally occurs due to decreased production or increased destruction. And if you see a patient with icterus, that means there could be some hemolysis going on, like in PNH. And of course, another big epidemic, if you could call it, is the presence of chronic liver disease, which can present with jaundice as well. So patients with chronic liver disease have a big spleen that can lead to pancytopenia. Never, ever, ever miss checking for lymph nodes, cervical, axillary, inguinal, because a lot of patients with pancytopenia with lymph nodes may have brucellosis, HIV, tuberculosis, metastatic CAs, and of course, lymphomas or leukemias. So the lymph nodal examination is as critical as checking for pallor in such patients because it helps you narrow your diagnosis down. There are so many causes of pancytopenia. Only if you go in with that particular thought process will you be able to narrow it down. Again, examination of skin, fingers for knuckle pigmentation, and changes that you see in connective tissue disease, especially like sclerodactyly, can commonly be seen in scleroderma. Leukocytia in CLD, joint deformity suggestive of connective tissue disease like severe rheumatoid arthritis. gum hyperplasia in the oral cavity in APML or M4, M5 type of leukemias, any markers of HIV, tuberculosis, or even chronic liver cell failure, sternal tenderness in hematological malignancies. So you must look at the patient from head to toe when you want to make a diagnosis of pancytopenia. When you examine the systems, hepatomegaly could indicate infiltrative disorders or even a malignancy. Splenomegaly is probably the most important organ that all of you require to palpate because moderate to massive spleen can cause hypersplenism leading to low counts. And the examples of hypersplenism leading to this can be because of portal hypertension, extrahepatic portal vein obstruction, or even lymphoma. So never finish examining a patient of pancytopenia without examining their spleen because that really points towards so many differential diagnoses and can help you rule out or rule in various diseases. Hepatosplenomegaly, both liver and spleen in lymphoma, leukemia, or some disseminated infections like HIV. One point sometimes you should always check the CNS because B12 deficiency can have neuropathy or even ataxia. Coming to the last part of today's presentation is the investigations. I've kept this for the end because I'm still old school like Nitin. I believe that you need to examine the patient, take an extremely good history, and then look at their investigations, right? There should not be a knee-jerk reaction to look at the investigations and then diagnose the patient. When you do a complete hemogram, obviously all cell counts are low. Critical to look at two things in a CBC. And I've just put up the important things for you: the reticulocyte count and the MCV. If the reticulocyte count is low, and by reticulocyte count, I mean the corrected reticulocyte count. If the reticulocyte count is low, the bone marrow is involved. This is decreased production. If the reticulocyte count is high, then that means there is peripheral destruction. So by just looking at the reticulocyte count, you can easily differentiate whether you're dealing with pancytopenia due to reduced production or increased destruction. Second, look at the MCV. If the mean corpuscular volume, that's the size of the RBC, is normal and the patient is pancytopenic, possibly aplastic, hypersplenism, or certain leukemias. If the MCV is high, that is, the MCV is more than 100, first thing you should think of is B12 deficiency, alcohol itself, myelodysplastic syndrome, drug intake like methotrexate or zidovudin, and PNH. If the patient has a low MCV, microcytic hyperchloremia, always say if there's associated iron deficiency anemia causing bleeding. So they may have pancytopenia due to, say, portal hypertension, and the bleeding esophageal viruses may cause iron deficiency. One more thing I forgot to mention here is whenever you see a low MCV, especially in a younger patient, always suspect a hemoglobinopathy. Some patients may go undiagnosed with TAL minor or TAL intermediate, which then can cause a big spleen causing pancytopenia. So therefore, you see, if you just look at the reticulocyte count and the MCV, you can make so many differential diagnoses based on these two tests. This is just if you look at a peripheral smear and these are the words you need to look for in a PS. Never look at the final report of a peripheral smear. Everyone tends to say, oh, normocytic, normochromic, and forget. No. You must look at how the pathologist has described each and every red blood cell. Blasts in leukemia, dysplastic WBCs in myelodysplastic syndrome. Shift to left could be myeloproliferative neoplasm. Hypersegmented neutrophils in B12. Schistocytes means there is peripheral destruction such as MAHA, that's microangiopathic hemolytic anemia, or DIC. Right? Nucleated RBCs are important. So look at the description, not just the final. This is just the classical Harrison slide. I had to put up one table from Harrison, which is the differential diagnosis of pancytopenia. I don't want to go into this, but this is if you get a bone marrow report, this is what you look for. Highly unlikely that any of you will get a bone marrow done, I understand. But if you have a bone marrow report in front of you, I'll obviously share my slides. Look at this particular chart. It will guide you. You will never go wrong if you follow this. The last part, what investigations are you expected to send? Liver function tests for indirect hyperbilirubinemia hemolysis. Look for infiltrated disorders may show an elevated alkaline phosphatase and GGT. Patient has low albumin, you're dealing with chronic liver disease. Always look for deranged PT-APT, but that could point towards CLD, DIC or APML, autoimmune workup, and infectious workup. I know these tests may be difficult to do in the rural setting, but at least whatever basic investigations you can do, you should be able to do to come to a diagnosis of pancytopenia. If you have access, to these particular scans: ultrasound, neck, axilla, abdomen, pelvis. And of course, I just put up CT thorax and PET scan just for completion's sake. But a basic ultrasound, a basic X ray is sometimes more than enough to diagnose. One last word: don't indiscriminately start blood transfusions. This is very important. Multivitamins, iron, give IV B12. Don't practice this particular way. Always remember, transfuse blood only if the patient has evidence of heart failure, and platelets if they are bleeding. Never transfuse unless you come to a diagnosis. Right? This is something that everyone should follow. A lot of patients who come to us have been given some oral supplement, some blood transfusion. It becomes very difficult for us because this changes the blood picture. And remember, if you have a patient you're suspecting neutropenia or neutropenic sepsis, antibiotics are must, because the antibiotic dose can save the patient's life. So if you're suspecting neutropenic sepsis, broad spectrum antibiotic, refer him immediately. Or even prophylactic antibiotics, if the ANC is less than 500, is okay till they are referred for further evaluation. Any questions?
Right. Thank you so much, Chaitanya. It was wonderful, as always, to go through how to sort of a textbook description approach to pancytopenia. And really, it's very important to have the knowledge of it as such, and then sort of translate it into a practical approach in the rural settings, and keep the mind open to what are the causes, and try to look for the common causes, and of course refer when these common causes are ruled out as such. So one of the most important questions that always come from bonders and also from patients, as you would have seen, is when you see anemia. We are moving away slightly from the topic of pancytopenia. When you see anemia, there are a lot of people who ask, is there any diet recommendations when the HB is 9 or 10 to improve? So do you actually think there's any role for diet in that sort of situation, or you again have to rely on IV supplements?
That's something that most of my patients do ask, in lot, very very common question.
Chaitanya, I
I
think
think
we have sort of lost signal with him.
audible now. Am I
Apologies for
audible
the.
now?
Yeah, Chaitanya,
Better
we lost
now?
you. Yeah, we lost you briefly there. So
Sorry.
essentially, is there any role for diet to improve hemoglobin, or do we have to stick to supplements?
That's a very good question. I always probably do both. I feel, especially given that one of the biggest causes of pancytopenia and obviously anemia is nutritional deficiencies. And these nutritional deficiencies are something that is, we are trying to tackle it, but it's still a very, very big problem. I always suggest, based on the cause of anemia, for example, iron deficiency, I always advise them to take an iron rich diet as much as possible. I advise them to take palak, green leafy vegetables, substitute sugar for jaggery, try to increase the amount of meat that they take in if possible. Patients who are vegetarian like us unfortunately suffer with B12 deficiency. So the very few food products that we have which have B12, but you can increase your soya intake or even your dal intake. That's the best thing. Or try to take some eggs. But I always feel that patients more than bonders get relief or some satisfaction if you tell them, instead of giving them a bunch of tablets, give them a few tablets, also give them dietary advice. I think that goes a long way in also putting the onus of improving the hemoglobin in their hands. And I think that's extremely important, to not just give supplements and tell them take this, but also suggest a good nutritious diet.
I think it's also very important to make a point here that if a patient is sort of symptomatic and has a hemoglobin probably less than 10/9, and you have diagnosed as iron deficiency anemia, you have to go back and read the pathophysiology of iron metabolism, because that is something that we are not going to be discussing here. So for relief, it is always better to give IV or oral supplements rather than relying on an iron rich diet, because usually if the iron stores are low and already hemoglobin has set in, then these supplements may not have any role. And at the same time, when you're giving supplements, if they take dietary intake based on the iron metabolism as such, the dietary intake may actually not get absorbed as such. So, very simply, what we would like to tell here is identify, is the patient symptomatic because of anemia, and is it nutritional deficiency? If it is nutritional deficiency, do give IV supplements or oral supplements if possible. Look at compliance. If they're not tolerating the supplements, also ensure that their diet is good. And most importantly, Do not ignore ruling out occult bleed or internal GI bleed, especially in males who have iron deficiency anemia. Most of the times, it can turn out to be GI malignancy as such. We have a question from uh, Helen Juliana. Apart from bone marrow transplant, any other treatment? I'm not really sure she's asking for what, but I'm assuming that it is for aplastic anemia or one of the malignant disorders.
Yeah. So bone marrow transplant is one option. It depends on the cause of pancytopenia. In aplastic anemia, yes, it is an option to do a bone marrow transplant. Less than, especially if the patient is less than 40 years of age. Some centers stretch it up to 50. But if you have a patient who's got myelodysplastic syndrome, there are various risk stratifications or even acute leukemia. Bone marrow transplant is something that has to be discussed with the family. But again, as Nitin rightly said, until you find out the cause of pancytopenia and you've established a diagnosis, venturing towards discussion of BMT may be a little preemptive.
How common do you see pancytopenia? Again, and this is something I'm asking on behalf of the bonders. How common is pancytopenia post an acute illness? So, if a patient is presenting with acute illness, a patient has had fever, sepsis, now recovering, and you see pancytopenia, what are the investigations that you would do?
This is again something that's really increased in the last couple of years. I don't know whether it's just post COVID, but we are seeing a lot of patients who have a transient illness or even a slightly shorter illness, maybe 7 to 10 days. And often or not, you won't believe they may not have a specific cause. Right? You may not get a Vidal test positive or a malaria positive or rickettsia positive. Treated with broad spectrum antibiotics, got better. And you will find that the bone marrow suppression can last anywhere from 6 weeks to 3 months post that. And usually, what we do is always check for HIV, hepatitis B, and hepatitis C because sometimes acute seroconversion can cause bone marrow suppression. And if you have the ability, Epstein Barr and CME sometimes in the right setting is something we test for. But most often than not, these are usually transient, and 6 weeks to 12 weeks, 6 to 12 weeks is the time for the bone marrow to recover from.
So, one question coming in from the bonders again on our WhatsApp group, which is what is the role of B12 injections and when is it recommended?
So again, this is if you have a documented B12 deficiency, of course, very very important to make sure the patient is on either IV or oral supplementation. As Nitin said, if they're symptomatic for anemia, it's always better to try the IV supplementation first. But a lot of times we find that the B12 levels, you may get a B12 report saying B12 is in the normal range or even more than the normal range. And you'll find that the patient would have taken some multivitamin over the counter or somebody would have prescribed to them. In that particular scenario, if you feel that your peripheral smear shows hypersegmented neutrophils, there is a macrocytic blood picture, it may be worthwhile giving them a trial of IV B12 for a week and then seeing if there's a CPC and reticulocyte response. Because sometimes the B12 value may not be representative, especially if the patient is taken a supplement prior. But keeping that in mind, there are certain myeloproliferative diseases which may present with a falsely high B12. So that is something also to keep in mind. So I would always suggest a trial of IV B12 for a week if you have a strong suspicion of B12 deficiency. If there's no response, then always evaluate further.
So, just to summarize the answer to your question, and this is something we even face in Bangalore in corporate hospitals or teaching hospitals, patient come with pancytopenia, but when we have sort of sent the B12, it always comes more than 2000. Now, when it comes more than 2000, invariably the patient would have taken some IV supplement at some other center and is now coming to you. So, like Chaitanya said, always look at the clinical picture. Look at high MCV, hypersegmented neutrophil, and a megaloblastic picture. Remember, there is a difference in the peripheral smear when you read a macrocytic picture and a megaloblastic picture. When you see a megaloblastic picture, it points again more towards B12, and it's always better to give injection B12, follow the protocol once a day for 1 week, then once a week for 4 weeks, and then once a month for 6 months. So daily for 1 week, then once a week for a month, then follow up monthly for at least 6 months. Sometimes it's difficult for patients to keep coming for the injections. So we say at least after giving daily for 1 week, you may transition to now oral supplements. There are some sublingual B12 supplements which are available. I'm not so quite sure of how available it is in the rural areas, but we would be happy if some of the bonders can share their experience of if there is any B12 supplements which they use in the chat box as such so that we can tell. Sister Lisa is asking a question. when do we give blood transfusion, what is the cutoff, and what are the scenarios in which we would use B12 supplementation. I would like to invite our next speaker, Dr. Royson, to be ready in the meantime.
So, blood transfusion is something that's extremely important for us to understand. When you see a patient with pancytopenia, it's not enough to treat his hemoglobin. As I said when I started off the talk, always treat the patient. If the hemoglobin is less than 7 and the patient is symptomatic for that degree of anemia, has evidence of congestive heart failure, then you are justified in giving a Paxil to relieve his symptoms. But as we see, patient with hemoglobin of 4 due to severe iron deficiency or B12 deficiency, there is no role for blood transfusion if they are not severely symptomatic for it. Unnecessarily blood transfusions are something that should be avoided. That being said, in the patients in the scenario of aplastic anemia, myelodysplastic syndrome, or leukemias, the target hemoglobin should be maintained above 7 if the patient has no cardiac disease, and above 8 if they have an underlying cardiac disease. The same thing for platelets. Less than 10,000 if they have signs of clinical bleeding, then less than 10,000 is the cutoff for platelet transfusions in patients with severe thrombocytopenia, and less than 20,000 if they have sepsis with severe thrombocytopenia. So these cutoffs have to be strictly adhered to prevent indiscriminate transfusions.
Right. Thank you so much, Dr. Chaitanya, for that wonderful talk on pancytopenia and the interactive discussions on really some of the burning topics as such as to uh, how do we go about treating such symptoms, when do we give transfusions, when do we give B12 injections, and when do we give supplements as such. Thank you so much. Right, it is now my
Thank you.
privilege to introduce our next speaker, Dr. Royson D'Souza. He's from the batch of 2009 MBBS from St. John's Medical College. He then did his MS General Surgery from CMC Vellore. A remarkable individual with a lot of extracurricular activities, basketball player, but more importantly, um, uh, dealing with a lot of rural experience because he worked quite a few years in the Gudlur Adivasi Center, done phenomenal work in the rural areas, and now even inspiring and guiding young medicos to work in rural areas as such. He is currently a fellow in the Department of Colorectal Surgery in CMC Vellore, and he has special interest in the field of malignancy. And I don't think there is anyone more apt than him to talk about something which is very close to the heart of most oncologists in this country, which is breast cancer. Because as we all know, as per the recent Globocon 2020 data, there are more than 2 lakh breast cancer cases in the country. But more often than not, it is in the rural areas where cases are missed or cases are detected late. So how do you really approach a breast lump? All over to Royson.
Thank you. Can you hear me, Nitin?
Yes, loud and clear.
Thanks for the wonderful and animated introduction as ever. It's my privilege to be part of this CME, and I think it's a wonderful initiative that the Johns alumni has taken over to guide the young candidates taking on the rural work for at least 2 years. Um, so, Nitin, I think, yeah, I'll be able to change the slide on my own. Okay, very good afternoon, everybody. I'll be talking about approach to breast lumps in a rural secondary care hospital scenario. So like Nitin mentioned, breast cancers are the topmost cancers in the world right now. According to the Globocon 2020 data, breast cancers have surpassed lung cancer and are the most common cancer in the world. And sixth most common cancer-related deaths overall. And in women, they are the major cause of the first common cause of cancer-related deaths. And in a country like India and other low and mid-low income countries, the problem we face is that most of these patients present to us in a very delayed stage, in a stage where we cannot offer them surgery and they become inoperable and only become a palliative kind of scenario. So why this is so important for you all who are going to take up rural service is that more often these patients would have presented to one of the primary health center clinics or a secondary care hospital with non-specific symptoms, and are often probably not been examined or have been misdiagnosed or have been reassured telling it's nothing to worry, and these are the patients who can potentially come back with liver and lung metastasis a few months later. So this is why I would like you all to pay attention to this session, and I'd be happy if you all at the end of this session will be able to make a diagnosis of benign versus a malignant breast lump, and how to approach a breast lump when, especially when it's cancer, in terms of clinical, radiological, and pathological aspects, managing them at secondary hospital level, when to refer them, and also screening for the breast cancers and taking a role of raising awareness sessions and health education in your in your setups. So I'd like to make it as practical as possible, so that since surgical topics are always better presented in case scenario way, that you remember better and you know how exactly to approach them. The first patient is a 24-year-old lady with history of breast lump in the right breast for the last 6 months with occasional pain. There were no other symptoms like nipple discharge or skin changes. There were no family history of breast cancers. On examination, it was something like that. You can see in the upper quadrant of the breast, there's a 2 into 1 centimeter mobile lump in the outer quadrant, with the skin over that being normal, nipple areola complex normal, and there were no significant lymphadenopathy. The opposite breast was normal. So what do you do when a patient comes like this? This is a young girl in her 20s with no other risk factors. So in today's era, I think any patient with breast lump, however benign you think it is clinically, please offer an ultrasound examination if it is readily available, or if the patient can afford to go to a center to get an ultrasound. Because ultrasound, even in rural hospital scenarios, even if you all have an ultrasound machine for obstetric purposes, if you all can just spend probably about an hour online training on or just watching some YouTube videos on how to do breast ultrasound, it's one of the easiest ultrasounds which will readily make you eligible and capable of diagnosing benign versus a doubtful breast lump. So what are the features of benign breast lumps? If the lump is cystic, if it's got a smooth margins and surface, if it's oval in shape, homogeneous and hypoechoic, they are most likely to be benign breast lumps. So, next question is, when do you offer an FNAC in suspected benign breast lumps? Definitely in patients who tell you that they don't want to undergo a surgery. So in here, you are taking a risk by asking the patient to wait for some time. So if you do not want to miss a malignancy, although clinical and ultrasound examination are suggestive of a benign lump, it's always better to have a pathology proven for these lumps, where you can safely instruct the patient to be on follow-up. And in patients who have a recurrent lump and the ones with atypical features like restricted mobility, firm inconsistency, equivocal ultrasound findings, it's always better to do a FNAC. So again, in today's world, any patient with breast lump, it is recommended that we straight away go ahead for a core biopsy, barring the patients where you think it's definitely going to be a benign swelling, benign lump, and the patient doesn't want surgery. In those cases, you can offer an FNAC. And FNAC is a very easy, simple test which can be done in any rural secondary hospital setting. So next thing is, if a patient, it's proven to be a fibroadenoma or a fibrocystic disease, and the patient does not want surgery, what non-operative management can you offer? Primrose oil was something that's was used traditionally, but there is no real evidence to support it. The recent evidence supports the use of a selective estrogen receptor modulator called ormiloxifin. It's the brand name is Novex. 30 mg taken twice a week for about 3 to 6 months can cause decrease in size in a lot of fibrocystic disease and fibroadenoma. This can also be used in patients who have a little bigger lumps, so that finally when they undergo a surgery, there is no big incision that needs to be made. And the patients who have a good response can be on follow-up with serial ultrasounds every 6 months. So that's about a benign breast lump. The second patient is a 34-year-old lady with a painful lump in the left breast for 4 months, with multiple discharging sinuses. This is again that I was commonly seeing in Gudlur in a rural tribal secondary care setting. A lot of rural hospitals see patients like this who come with painful breast lump and on examination find to have a lot of discharging sinuses, and often they are misdiagnosed to have tuberculosis of the breast, and they can also give you some confusing or misleading history like having had TB 10 years ago or family history of TB or some evening rise of temperature, etc. But remember, a patient who presents with something like this is very classical of a condition called idiopathic granulomatous mastitis, which is very commonly seen even in rural hospitals. And often they are misdiagnosed and the patients will be on antitubercular therapy and develop all sorts of complications because of that. So this is a benign inflammatory disease of the breast and is commonly misdiagnosed to be TB. The treatment, remember, it's not ATT or doxycycline or antibiotics. The treatment for IgM is pulse steroid therapy with prednisolone 30 mg every day for 10 days, followed by a gap of 1 month, and you do this cycle for 3 months, 3 cycles. In patients who have extensive involvement of the skin or recurrent abscesses and poor response to medical treatment, you can consider surgery, which would be a debridement of that lesion, and followed by again a pulse steroid therapy. Third case I would like to discuss is a 64-year-old lady with a history of painless lump in the left breast for 2 months. There was no nipple discharge or skin changes. This lady had attained menopause at 50 years. There were no significant family history of BRCA-associated cancers. This is a familial syndrome, BRCA sequence, where they are predisposed for breast cancer. Men are predisposed for prostate cancer. Other than that, they can have uterine and ovarian malignancies. So it's very important you ask this history in women with suspected breast cancer, and other high-risk factors like use of OC pills, hormone replacement therapy, duration between childbirth, breastfeeding, etc. So on examination, there was a 5 by 4 centimeter lump in the left upper quadrant with irregular surface, hard consistency, and restricted mobility. There was no involvement of skin or underlying pectoral muscles, and the left axillary lymph nodes were not palpable. Always remember, when there is a lump in one breast, always examine the opposite breast and axilla as well. In this patient, the right breast and axilla were unremarkable. So, like I was saying, in a patient with suspected breast cancer, you need to take a detailed history, age, and the other risk factors, menstrual and obstetric history, family history of breast, ovarian, uterine, and colonic malignancies, previous breast biopsies, which also is a risk factor, and breast lump excisions, which are risk factors to develop cancer at later period. On examination, you have to thoroughly examine a primary tumor, just like how any of the surgical textbooks describe. You have to examine them with the extent and the examination of the lymph nodes and features of metastasis. So how do you evaluate a suspected carcinoma breast? It is triple assessment, like all of you probably know, which is clinical, radiological, and pathological examination. Clinical, I've already mentioned, a thorough history and examination. Radiological, most of the rural hospitals will have availability of ultrasound. Ultrasound is a very important and a feasible tool that can be used to diagnose breast cancers. It is definitely indicated in women less than 30 years, and in selected women with who are more than 30 years of age. In other women who are 30 years of age, the modality of investigations, imaging, will be mammography, which again may be a barrier in most hospitals, and you may have to refer a patient. So with ultrasound and mammography, most of the breast lumps can be diagnosed as benign or malignant. In selected individuals only, we recommend an MRI, which is a premenopausal woman with dense breasts and equivocal. So if the ultrasound or mammogram are not definitely suggestive or are giving equivocal results, you can consider MRI. In patients for screening with BRCA mutations and the patients who've had recurrent breast lumps, MRI can be considered. This is a universal way of reporting a breast ultrasound and mammogram. It's called BIRADS, Breast Imaging Reporting and Data System. So just to remember that if your patients come with an outside report saying BIRATS 0, so remember that it's an incomplete evaluation and needs an additional imaging. BIRATS 1, 2, 3 are mostly benign and can be on follow-up, whereas BIRATS 4, 5, 6 will definitely need a biopsy, and BIRATS 6 means a biopsy-proven malignancy, which will need further treatment. So the core biopsy, again, this is a useful link that I've put up here. You can go to, Nitin, I think the slides, sorry. So you can go on YouTube channel and search for rural surgery videos, and there you will have how to do a core biopsy of a breast lump. It's a very easy technique, and this in fact was recorded in Guddur Adivasi Hospital and was being performed by one of the born doctors. So it's an easy thing. You just need to invest in getting a core biopsy needle, which can be sterilized and reused in at least 20 patients. So the management of the patient that I just spoke about, clinically this was a T2N0M0 lump, and the patient was eligible for an upfront operation. She underwent a modified radical mastectomy. So when you do a mastectomy, always get a hormone and the other immunohistochemistry markers like estrogen receptor, progesterone receptor, and HER2/neu. So here it was hormone favorable, and then she was on hormonal therapy. So a clinical way of classifying breast tumors would be operable breast cancers, which are less than 5 centimeters with early lymph node changes, large operable breast cancers, which are more than 5, but in an individual who can undergo a upfront surgery. Locally advanced breast cancer is when the chest wall or skin are involved, and fixed lymph nodes, and metastatic breast cancer. The fourth case is a 55-year-old lady with a painless breast lump for 2 months and no other high-risk features. On examination, she had a 3 into 3 centimeter lump with irregular surface and restricted mobility. No axillary nodes were palpable. Her ultrasound was BIRATS 5, which means it's highly likely to be malignant. And a core biopsy was suggestive of mucinous carcinoma. This is just to emphasize that even in rural hospitals, there may be patients who would want breast conservation surgery, and this is possible in rural hospitals with an operating room. This patient underwent a breast conservation surgery, which was essentially a lumpectomy with 2 centimeter margin around the lump with right axillary lymphadenectomy. The final histopathology was consistent with a mucinous carcinoma, which was ER/PR positive. But one thing that you have to counsel all patients who are eligible and want breast conservation therapy is that they have to have radiation therapy after the operation. That is mandatory. So they would also require a pre-op ultrasound and mammogram and complete resection of a primary tumor with at least 1 centimeter margins. The contraindications would be multifocal disease. That is, if the patient has lumps in multiple quadrants of the breast, history of prior radiation to the chest, if the patient is pregnant, if there are positive margins, or if the patient has a small breast with a large tumor. So these would be contraindications, and all the patients with BCS will definitely require an adjuvant RT. The last case is a 45-year-old lady with painful lump in the right breast for 3 months. When she presented, she was emaciated and was in sepsis. There was a large tumor occupying her entire breast with copious seropurulent discharge and maggots in the wound. She was very frail, and she had multiple right axillary nodes which were fixed. On further evaluation, she had low hemoglobin, elevated alkaline phosphatase. Her chest X-ray showed something like this. So these are cannonball lesions suggestive of multiple lung metastasis. Ultrasound was suggestive of multiple liver metastasis and ascites. So you may get patients like this, and the last thing you would want to do is subject them to go to a faraway tertiary care center, subjecting the family through the trauma of the whole thing, where they probably have to wait for days together to get an appointment, probably get admitted and undergo another evaluation. Remember, irrespective of the best efforts and best treatment, these patients are not going to make it. So if you have a facility to admit the patient and can explain the prognostication, saying this is a very advanced disease, and counsel the family that there is nothing more that can be done, and you can offer the patient best comfort care, which is what we did for this patient, and the patient succumbed within a week to the illness. So the mortality most commonly is due to liver mets, followed by respiratory insufficiency, MI, brain mets, infections, DVTs, bleeding, and treatment-related complications. This is just for theoretical interest and overview of TNM staging, which I'm sure all of you would have studied for your final exams. The T staging is based on the size and the extent of the tumor, 2 to 5 centimeters. More than 5 centimeters would be T3. If the tumor is fixed to the chest wall, it would be T4A, to the skin would be T4B, and T4D is inflammatory cancer, which rapidly spreads. Lymph nodes, again, is classified as N1, N2, and N3. This is just a depiction of T staging of the tumors, and this is the lymph nodes. So, just for your clinical interest, if the axillary lymph nodes are palpable and are mobile, it's N1, and if they are fixed, it's N2, and if supraclavicular nodes are palpable, that's N3 disease. For staging, you may want to do ultrasound and mammography of the opposite breast, chest X-ray, bone scan, ultrasound abdomen and pelvis, CT thorax and abdomen only in patients with locally advanced tumor which are fixed to the skin and chest wall, and PET scan only in selected patients. The surgical treatment is the mainstay. The goals of surgery is achieving a complete resection with negative margins, pathological staging of the tumor, and axillary nodes for prognostication. So there are various types of surgeries ranging from lumpectomy, wide local excision, which is essentially a breast conservation surgery, simple mastectomy, modified radical mastectomy. We have kind of gone past the era of radical and extended radical mastectomy because we have fantastic people like Nitin who can give us neoadjuvant chemotherapy and downstage the disease, and patient can have better surgical margins. So this is an algorithm of operable breast cancer. If you diagnose a patient with a breast cancer who can undergo an upfront surgery, do an imaging and biopsy in terms of triple assessment. If the patient wants a breast conservation, you can, and is eligible, you can offer. If the patient wants breast conservation but is not suitable, you can offer neoadjuvant chemotherapy and reassess. But if the patient is not suitable or does not want BCS, you can upfront offer modified radical mastectomy. In large operable breast cancers, always do a metastatic workup with ultrasound, abdomen and pelvis, chest X-ray, bone scan if possible. If there are no mets and surgery is feasible, you can offer upfront modified radical mastectomy. If it's not feasible, definitely advise them neoadjuvant chemotherapy and assess for response and further plan. The systemic therapy, this is again for those who are working in hospital which function with Chief Minister CM insurance scheme or the other schemes, because most of these chemotherapy agents are available with these schemes. So anthracyclines and taxanes are available. So this adriamycin, cyclophosphamide, epirubicin, and cyclophosphamide with a taxane is something that's commonly used and can be made available under one of these insurance schemes, and you can even give them in your own bond hospitals. Hormonal therapy is with tamoxifen, which is a SCRM, and it can be given in premenopausal women for 5 years. And I think the current recommendation is you can give up to 10 years as well. In women who are postmenopausal, aromatase inhibitor like letrozole can be given for 5 years. Trastuzumab is another monoclonal antibody. It is specific for patients who have positive receptor for HER2 new, and yeah, this is given for 1 year, which can be given in both neoadjuvant as well as adjuvant setting. Radiation therapy is specific for breast conservation, as well as patients after mastectomy who have lymph node positivity, T3, T4 tumors who have high risk of local recurrence, positive resection margins, and known residual disease in the axilla. I would encourage you all to go through this case series that we brought out when I was working in Gudlur. All the patients in this case series were managed in a rural secondary care hospital. It just gives you a clinical scenario as well as an overview of how to go about each of the different types of breast tumors that you probably will encounter. And to conclude, please have a high index of suspicion with when patients present to you with breast lumps. Do not disregard even the smallest of the symptoms. Do a thorough clinical examination, liberal use of ultrasound to diagnose high risk features, FNAC and biopsy if available and feasible. And another thing I would like to emphasize is, as rural doctors, you will have a defined population that you will cater to, which is not possible in tertiary care centers. So here you can take up roles like health education, awareness camps and programs on just to train women how to do breast self-examination. What is a problematic lump? Most women in India still feel that if there is a lump and it's painless, it's nothing to worry about, which is absolutely wrong. Painless breast lumps are the most common presenting symptoms of breast malignancy. So you all have to take lead in arranging these awareness programs. And some useful links that I would recommend is Johnite Academic's WhatsApp group, which is very, very useful. It was started when we started doing Bond, and from that time onwards, I've seen that there is battery of information and learning that can happen on that group. However stupid you may feel it is, you may as well save a patient and look stupid than the other way. Rural Surgery YouTube channel is again something that will also have videos on small procedures like biopsies, debridements, local anesthesia, etc. And Rural Hospital Network website as well has a lot of information. Thank you, and I hope the session was useful. Thank you, Nitin and Alumni Association.
Thank you, Royson. Gino is waiting in the green room, the virtual green room, and wants to correct and is making all sorts of action to say that the Johnite Academic WhatsApp group was started by the batch of 2007 during their Bond time and not during your time. But anyway, fantastic. Thanks so much for that wonderful talk, and truly you have been a good resource and a great resource for the bonders in the WhatsApp group when it comes for the surgical issues as such. So very quickly, I'm taking in some questions, and the one question is, when should you not operate when you see a breast lump? So everyone says, when should you not operate? When should you refer to a higher center when you see a breast lump?
So my suggestion is never operate unless you have a biopsy, especially if there are atypical features like restricted mobility, older age, if there are risk factors for breast cancer, always do a biopsy. And in today's world, the teaching is if you do a biopsy, however small the lump is, if it's a triple negative breast cancer or if it's HER2 positive, it's always better to give some form of neoadjuvant and then offer a mastectomy. But having said that, if a patient presents with an ulcerative lesion in the breast and you think the patient requires an urgent debridement or a mastectomy and you have the facilities for that, please go ahead. And also, if it's a benign lump in a young girl who wants the operation for cosmetic purposes and there are no other risk factors, you can definitely offer an excision and do a biopsy. Definitely send biopsies whenever you operate. And in patients with suspicion, please do a biopsy and then go for an operation.
I think the very key take-home point here is, I don't think people in rural areas should be offered less standard of care with people operating even when there is a suspicion of breast cancer. I think we have enough resources or enough where we can direct them to centers or regional cancer centers where neoadjuvant treatment protocols can be given. Please always, this is a message even from my side, please do a biopsy, and a biopsy is just not enough. Do not see a diagnosis of breast cancer and go and operate. These days, we talk a lot about the biology of the disease. It is important to get IHC done. And please try to get in touch with us. India is expanding in terms of cancer care to rural areas, and we will be able to help you out in most of the cases to ensure that adequate staging is done. The next question which comes is really, and that is something we encounter on a daily basis, which I'm sure that a lot of people who visit our rural doctors ask, does biopsy increase the risk of spread of cancer?
Well, it's a very interesting question. Biopsy or previous operation on a breast is a risk factor to develop malignancy in the future, but that should not prevent you from doing a biopsy, because biopsy is a very crucial step in deciding the treatment for a patient. So if there is a patient with a breast lump, please do a biopsy. That's not going to spread. It's not like a biopsy of a testis where there could be seeding to the scrotum. Breast cancer will not spread like that. But please make sure that the area where you biopsy, your incision or the puncture site should be something that will be included in the surgical specimen when the patient undergoes a surgery. So it should be right on top of the lump and should not be at a side, because they will have to radiate that area as well if it's positive, as well as include that in the surgical margin. So this shouldn't discourage you from doing biopsies. Please do biopsy. It's very simple, and it's, I think, one of the most important aspects in cancer care for breast.
And I think one of the more important points that you touched across also is, please take a good family history. I think it's important to recognize that 15 to 20% of breast cancers are hereditary. So please ask for family history, because then you can also subject them to risk reduction surgeries and talk about it. And like Royson said, please conduct health awareness camps about self breast examination. Try to get in touch with NGOs to organize screening camps with mammograms. Try to get in facilities, because we really need to combat something which is becoming epidemic on a large scale. So the last question is from Sankalp, who says, any particular drugs for palliative care in CA breast?
Yeah, thanks.
I think
Yeah, it's a very important question. The best or the least you can do to a patient who's dying of a cancer is keep them comfortable. So most tumors, even if they are ER/PR negative, you can give them tamoxifen and letrozole. That itself offers some palliation. Good to see you, Gino. And other things that you can even offer is things like morphine. In most of your rural hospital will have Fortwin, Phenergan, etc. Buprenorphine. These things you can give to patients, because it's very painful if it's ulcerative or if it's spread to bones and all. They'll have a very painful death. Just because they are in a rural hospital, please don't deny them of good analgesia. You may as well keep them sedated than them, having their last days crying in pain. That's my suggestion.
And what I would like to add is, there's a difference between palliative care and end of life care. What Royson has talked is a lot of end of life care and supportive care, but there are medicines for stage 4 breast cancer. If they are hormone positive, we now have simple oral tablets which you can give them, which does improve their quality of life and prolong survival. If they are HER2 positive or triple negative, we do have other medicines which may be slightly expensive, but it's very important that in a patient, just because he is stage 4 by imaging, but he or she, if she is sort of well nourished and leading a decent quality of life, it's important that we give some form of systemic therapy to prolong survival with a good quality of life as such. So let's not forget that. Thank you, Royson, so much again for this wonderful talk on how to approach a breast lump. Thank you also for connecting with some of the other speakers who are going to be talking in the CME. You were the president of the 2009 student committee in St. John's. And from one president, we now move to the other president of the 2007 student committee as such, Dr. Gino Joy, who in fact has a very interesting story, who during his internship wanted to do many subjects. Every department he was posted in, he liked that subject. But after doing his rural service in Chengalam, got thoroughly interested and passionate about geriatrics, and went on to do MD Geriatrics from CMC Vellore, and is today a consultant geriatrician and leading geriatric care in Cochin by being a consultant geriatrician at Medical Trust Hospital. Gino's signal is a little weak, so we apologize for any lags or delays that we have. But Gino is going to be talking about quick geriatric assessment in the rural OPD, what not to miss in the elderly. Gino, all yours.
Thank you, Nitin. Hello, Nitin. Am I audible, Nitin?
Yes, Gino, you're audible. Go ahead.
Hello.
We can hear you, Gino. Go ahead.
Okay, thank you. It's good to speak after Royson. Like Nitin rightly mentioned, Royson was from our baby junior batch. So that makes me feel more geriatric than ever. I mean, to have your baby address before you and then speak after him. Anyway, thank you. That was a wonderful session and a good initiative by St. John's alumni. I must congratulate. Wish we had something like this during our time. But the least we can do is at least fill in the lacunae and step in wherever we can help. Very happy to describe to you about a quick geriatric assessment. So when it comes to an older person, this is probably something which is very typically what comes to our mind. A very frail man, very probably dependent. When it comes to hospitalization of older people, we tend to assume that older people kind of present you in a very sick and very deprived state. So when the journey which Nitin was describing, when I was about to choose geriatrics as well, so a lot of people thought that I would be dealing with patients like this. But then what I am dealing these days, or what I am seeing, are probably patients of this nature. As you can see, most of our movie stars, veteran political leaders, most of them, name them, they're almost all of them are about 60, and all of them are probably well, fitting into the geriatric age group, and probably should be consulting a geriatrician at this point, because age is the simple most criteria or the single criteria where we decide whether they're going to be addressed as a geriatric issue or a non-geriatric issue. So when we see older adults, this is probably what we see. I think some of the Malayali crowd can relate to the picture here. This was from the movie called E Parakam Taliga. This movie has been remade in Kannada, Telugu, Tamil, and even Hindi, I presume. So where this group of youngsters who are running an old bus, which is titled after his dad's name, are trying to, camouflage the appearance by putting in a lot of planktons and a lot of other things in front of that. So most of our older adults actually present you like that. But the truth is, once you unveil, once you take away all those decorative items, they are, at the core, probably having a engine trouble, probably having worn out wipers, probably having lack of headlights, probably the gearbox is in complaint. But most of the times, they might not present to you in a worn out state, especially with healthy aging and active aging in consideration. Older people tend to present very normally, and the deficits in them would be actually hidden in them. So, as I've shown in this slide, there is a spectrum of frailty. So frailty again is a very common term which the geriatricians would love to use whenever you try to describe about any illness. We say that okay, this is because of his frailty. So frailty is nothing but that body's inherent, lack of capacity to defend to the external stimulus as they age. For example, when we had COVID, we had older people who succumbed to it. The reason could be simply frailty, because when you're exposed to the same virus, same pathogen, they're unable to withhold, or they're unable to, give a resistance or a fighting power to the infection. That's probably which can be termed as frailty. But when you look at the spectrum of frailty, you see a very robust, walking, talking Narendra Modi kind of gentleman at one side. Then you have a very dependent, people who are dependent on other people for their daily activities. The end of the typical older adult, very, very frail people at the other end. So the people who have been indicated in the boxes, especially the rural doctors, must give due attention, because the people who are in the center, people who are a little bit frail, people who have little diabetes, people who have little hypertension, people who have some knee pain, people who have some, vague aches and pains, they are more likely to come into your OPD because they will present with some sort of a complaint to you. The people who are very robust, the people in 70s who are running around and thinking that they don't have any illness, probably those are the ones who are being missed because they have geriatric issues as well. Because you should remember, every 70-year-old person will have a 70-year-old heart, 70-year-old eye, 70-year-old kidney, no matter how robust they will appear from the outside. And then the other end of the spectrum, where people who are bedridden, people who are being wheelchair bound, they probably might not be even visiting you in OPD. And these are the two ends of geriatric care, which is generally missed in a rural OPD. So as you can see, as we move on, a role of a comprehensive geriatric assessment comes at a point where you can prevent them from slipping on to a more bedbound or a more supportive care. So many people often misunderstand that geriatric care is equivalent to palliative care. No, like Nitin was earlier pointing out, these terms are very often used. People confuse about it, but palliative care is probably the other side, where you are trying to support them with whatever resources they have to live and have a peaceful and a pain-free life. But geriatric care is an acute care. It's just like how pediatrics takes care of children. Geriatrics is just probably a medicine specialty which takes care of older people in acute as well as chronic illness. So the target there is to do a comprehensive geriatric assessment at the outset to pick up issues which may progress into a dependency state. So what happens in a geriatric care? Again, as you see, it's not about the care. We are talking today about a quick CGA, or a comprehensive geriatric assessment, which you should probably do for every person who comes with 60 plus into your OPDs. Various domains which will be checked up there: the cognitive domain, the neuro functions, the medical and psychological issues, main geriatric syndromes, and multiple other factors which could have a deleterious effect on the older adults and their life ahead is what is trying to be picked up in a CA. So today in the talk, we will be focusing on specific syndromes and trying to help you how to get more out of the history when a 6-year-old comes into you. I would strongly recommend that you should practice this for every person, no matter what complaint they come with, whether they come with diabetes, OA&E, or whatever. It's a very easy and helpful manner to know the older person in front of you. So more demography to begin with. Every history class or every medicine class or every community medicine class, we are obsessed on demography. In older adults, I want you to take three important points from them in addition to the usual demography you get. You have to find out who do they live with, because you shouldn't assume that the son or daughter who brings in them to your OPD is living with them. For all you know, this older man or older woman might be actually living alone. The spouse who's living with them might be already bedridden and they might not be in a shape to take care of them. They might be having a home nurse, a maid, or whatever, or they might be actually representing or coming from an assisted living facility. It's very important to understand, because when you plan an intervention without knowing who's staying with them, there's no point in planning that intervention. And then ask them about financial independence, because many older adults in rural India are actually dependent on their elderly pension, which is as low as 1,000 rupees. So probably they are getting 1,000 plus 1,000, 2,000 rupees. That's all they're probably having for their livelihood, and you cannot be prescribing medicines worth 1,000 rupees to that elderly couple. So it's very important to know what is their income source, rather than doing all Kupaswamy and all the classifications. The absurd ones. The main thing is to find out how much they can afford for medical health care. Are they having insurance backup? Are the children going to help in case of a need? Document and keep it, so that even if you leave your bond hospital, the new doctor who comes in knows that, okay, Mr. X and Y has this kind of a resource in place. Definitely don't assume again that the son or daughter who's coming is a primary caretaker. I always, even now, make it a point to get a number of a person who will be responsible. It might be a nephew, might be a neighbor. Get the number of that person who would be responsible, because I have had instances in my bond hospital where elderly gentlemen are brought in an auto. They come into your OPD with chest pain and they collapse. And then you wonder whom to call, because the numbers which they're given are the numbers of a son who long back left to his Middle East, for his livelihood. And then there's nobody whom you can connect and talk to. So identify a primary caretaker whom you can contact in need and list in your case sheet. So moving on. We also, beyond demography, we will have to do a comorbidity listing. Now, if you ask me, this is my most favorite segment of doing a comprehensive geriatric assessment, because to sit with them, to identify every small thing which was done in the past is very important. See, they would have come to you for a backache. It is very easy to write in your chart, complaints of LBA, advise paracetamol, get out of my OPD. It's very easy. But then, if you take the time and patience to write down every single issue they had, your document could behave like a passport, a health passport for them. I would like to, quote my professor in CMC, Dr. Prasad Matthews, when we used to prepare our discharge summaries. If any one of you have come across a CMC geriatrics discharge summary, you would see the diagnosis page runs into 2 sheets, most likely, because every single problem to the minutest complication is listed in that paper. Because, like Dr. Prasad always used to remember, this might be the only opportunity for that older person to have a comprehensive evaluation. And if you, as his primary doctor, list down every single problem, a doctor who's probably way more busier than you, somebody who's not very interested in taking care of the older adult, might not miss an issue which has happened in the past. Like you can see in this slide here, I've tried to list for a patient, what are the diabetes, when did it start, what are the complications going on, okay, what are the inactive issues. Okay, then whenever next time he complains about a vertigo, you know that he has a history of BPV, which will help you actually address issue faster. So take time. Lot of probing has to be done, because even the patient might want to just finish off by telling you about his acute issue, but then sit with them, get a list of comorbidity listing right at the outset, and this will help you gain more confidence, because patient will understand that you are more interested in getting to know what the patient had rather than rushing through a prescription. Moving on. So now you got the list of the medicines. The next thing you have to do in every older adult is a drug reconciliation. So this doesn't end by actually getting, to ask them, okay, what are your medicines you're taking? And then they will name you losartan, metformin, and two, three drugs. That's it. No, you shouldn't stop by that. As you know, most of the older adults have a pill box, and it is a Pandora's box always. You open it, you will find that there are a lot of things. There are n number of things. They would have met Dr. Nitin, who would have prescribed them something. They would have met Dr. Royson, who would have prescribed them something, and they would be keeping all this in stock because they'll think that, okay, I can utilize it whenever I need. And sometimes they might be abusing it because they would have gone to Royson once for, say, a rectal bleed, and Royson would have given them some medicine. They might assume that next time I have it, I just use it. So open and see and ask them, identify what this medicine is used for. And I try to give a list, if you can see on the screen. I try to give a list rather than getting a prescription from them. I tell them and I encourage them to maintain a list and to write it down. Okay, drug number one, metformin 500 milligram, prescribed by Dr. So and so. And what is that medicine given for? I ask them, what is your understanding? They might say that metformin was given for my urinary symptoms. So you have to make them write that, and then you have to tell them, no, Dada, this is a medicine which is given for sugars, and help them understand what their medicines are so that when there is a change, because most of the older adults will end up doctor shopping. They'll go to many doctors, though they might trust you as a primary physician. They might visit a nephrologist. Their over enthusiastic son or daughter might take them to a neurologist, cardiologist. All of them will give them medicines, and once you reconcile, you will find that a lot of polypharmacy, lot of overlap, lot of supplements, same medicines in different combinations can be cut down. And believe me, at least 50% of the problems in older adults can be managed by drug reconciliation and drug optimization. Again, it's a very painful process, but once you do it and insist that you bring your medicines every time you come to hospital, they will do that. We have a notice put up in our notice board, I mean, right outside my OPD, telling that please bring all the drugs every time, because even an inhaler, you can see whether they're using it, correct it. So it's not just about reconciling, it's about having a control on what your older adult is taking, and the primary care physician at the rural hospital should be the person, I believe, is responsible for that. So when it comes to vaccination, make it a point to see whether they are COVID vaccinated in rural area. So don't, like Royson was telling, just because they are from rural, there is no need to deprive them about available vaccines. There are people who are affordable. Please tell them about annual influenza vaccines and pneumonia vaccine and 10 yearly ones TT vaccine as well. So make a note of that, encourage them to vaccine. That's about the vaccination status part. So moving on, functional status. Again, a very important thing to analyze and see, because see, a lot of people you might be seeing, they're coming in a wheelchair, but they're actually walking at home. A lot of people whom you are seeing who are coming in with support to the OPD might be actually doing nothing else at home, and they might be dependent on other people for their assistance. And whenever a illness worsens, whenever their physical condition worsens, what gets limited is probably the functional status. And if you ask any older adult what they want to preserve in their life, do they want to be sugar free? Do they want to be heart attack free? Do they want to be cancer free? The single thing they would say that all I want to is walk free, do my things independently. So preservation of functional status is most important. How do you know how their functional status are preserved? You can tabulate it by checking activities of daily living or ADLs and IADLs or instrumental activities of daily living. So what are the activities of daily living? So the activities of daily living are the activities which are required for your normal day-to-day life, like bathing, maintaining a dental hygiene, going to toilet, going eating by yourself, feeding, dressing, basic transfer and mobility. A simple scale you can use is Barthel's index, which is available in MD, Cal, QXMD, and all that. So based on Barthel's index, out of 20, you can write a score and keep and list what is the functional status of 2022 December 17 and whether 2023 December 17 was it worsened or not. Instrumental activities of daily living, however, are activities which are a little more sophisticated, or rather things which they would want to do and preserve in their life, like going out and shopping, doing their banking. So if they are getting compromised on this, even early dementia, early Parkinsonism, once these things are getting compromised, more likely that they would be will remain confined to their homes and become more sicker as they go. So this is also very important to ask them every time whether they are able to do these things as well. Moving on. So what do we see about geriatric syndromes? So geriatric syndromes are, if you want it to be brought into a very simple terms, are those symptoms which are often brushed down, often brought down by the treating doctors, telling that okay, this all happens with age here, age related. Like when somebody tells you about not able to hold their urine, you tell that it's age related. When somebody tells you about, see, I'm forgetting things, you tend to say that this is age related. But see, these are all syndromes which can independently evolve and have substantial implications on the functionality of older adults. So in the next part of CGA, we are trying to try and identify these syndromes. Among these syndromes, the first one we would try to screen is depression. So to screen depression, what is the easy tool which we can use? As you can see in the next slide, depression can be screened efficiently by using a PHQ questionnaire. Nitin, can we have the slide move? So PHQ2 questionnaire is a simple questionnaire where you try to ask the patient whether they have stopped doing something which they found interesting or which they used to love before, or whether they simply, you can just ask, are you feeling depressed? Are you feeling let down? Are you feeling sad? Once you ask that simple question, that's a very easy and effective way to connect and know more about depression. Obviously, you can use scales like PHQ-9, GDS or geriatric depression scale and all, but in a busy OPD, we are talking about asking simple 2 questions and getting away to know whether your patient is depressed. Believe me, in post-pandemic era, most of your older adults, about 60 to 70% of them, are actually depressed when you score with a simple tool like PHQ2. So moving on from depression, the next major hurdle probably most of the older adults tells you or reports to you is about cognitive impairment. Even if they deny cognitive impairment, because most of the older adults think that preserving older memory is very important, and they say that, doctor, I can remember everything about my childhood. But then when challenged about a recent event, they tend to forget. And that's precisely how dementia progresses. So don't go by, if you ask them, are you having any memory issues? Many of them will say no. But then do a simple 3-word recall test. It's as simple as just telling them 3 random words to remember. I usually tell them, see, please remember pen, apple, train, and then make them repeat after you. Tell me what I just said. Ensure that it is registered into their brain. So see whether they can actually have an immediate recall. So pen, apple, train, and then they have that registration intact. See, basically, when somebody is having a bad attention, when somebody is delirious, you cannot actually do a cognitive assessment. So ensure that they can at least register what is being told, and then have a recall at the end of the interview. So I tell them at the beginning, so I'll have these 3 words, and you tell me when you leave it. So adding on to that, you can, somebody is not able to recollect one word, or somebody is not able to recollect, then you can actually make them do a clock draw test. So clock drawing is simple. These are some of the clocks which our demented patients have drawn. But clock drawing again is a very simple exercise. You tell them, I want you to draw a clock, a face of a clock, which is round, and I want the numbers 1 to 12 in that. I want a shorthand. The hour hand is the minute hand should to be there. And you tell them an arbitrary time. I give them either 10 minutes past 10 o'clock or 8:20 as a time. So all these graphs which are shown in the picture in the slide are wrong. Basically, you'll have to see whether they are exactly comprehending and drawing a round clock with the sharp time which you have told. So when you combine a clock drawing test and a 3-word recall, that is called mini clock test, that is almost 97% sensitive and specific as well. So you need not go in and waste your time by doing a full MMSE, MOCA and all. You can actually identify very quickly whether there is a true cognitive impairment or not by doing this test in your OPD. So moving on, again, the next probably the most important issue is again falls, because many older adults have either fallen down or they are at the risk of fall. And as you know, a fall and a fracture is probably even more riskier than having an MI, because there is almost a 50% 1-year mortality with a hip fracture in an older person. So how do you screen? So whenever you encounter a new older person, you should ask them, have you fallen down at least once in the last 1 year. Even a single fall, whatever be the reason, whether it's slip and fall, whether it's trip and fall, whether somebody pushed them and fell down also, that's significant because they have a risk of another fall happening in the next 1 year. And if they had a fall, try to find out whether they sustained any fractures, any injuries were there, whether these fractures, falls were associated with LOCs, loss of consciousness, because you're trying to see whether there was a syncope, whether there was a seizure, and then you're trying to see whether they had any. Please go back to the previous slide. We are not done. So whether they had any previous issues with that, are they using any mobility assessment device, in the sense, are they using a walking stick? Because some son would have come and given them a tripod stand, might not be an appropriate walking aid for them. So you see whether they are walking, efficiently with that. If not, try and give them a better aid, because in rural area you will see that most of them are happy walking with a walking stick, but the walking stick might be actually increasing their falls risk. So get a help of physio if you have the luxury, and give them a proper assisting device as well. So moving on, the next commonest complaint, again, patients report to you is about their bladder issue. Many women would come and tell you about stress incontinence, like they will say that when they're coughing or laughing, they have a little bit of urine leaking. Men would say about urge incontinences when they have to have difficulty in controlling their urine. Nocturnal frequency increased, peeing in the night. If somebody goes to toilet more than once after they have slept, so that qualifies for a LUTS, a lower urinary tract symptom in the night. So whether there is a poor stream, whether they have a sense of incomplete voiding, whether they have sensation of dribbling, any of these things, it's very important to pick up, because a lot of pharmacological and non-pharmacological interventions can be actually done. And patients often don't tell you this because they think that this is part and parcel of their life and they have to live with that. So as a rural doctor, you should definitely ask this in their older adults as well. The next very common issue which older people have is with their bowel. So many people, older persons, they assume that passing stools once in 2-3 days is okay. No, it's not okay. You'll have to pass once a day at least. And when they pass, many of them actually, if you see the Bristol stool chart which we have given there, many of them would be actually passing very pellet type stools. If you ask the older adults, they would say that my stools are like pellets. That's not a normal bowel. So that's equivalent to constipation, and you need to have a sausage-shaped stool. So for that matter, unless you ask them, you might not tell, because they might be okay with their bowel movements, and then some of them might be wanting more bowel movements. But then you can reassure them that if you're passing at least one proper stool a day, that is good enough to carry on. And some of them could be having a bowel incontinence as well, especially postprandial urgencies, inability to control bowel in neurological issues. These, unless probed upon, cannot be picked up. And if you don't pick it up, that causes a lot of discomfort, not just about discomfort, that increases the risk of infection, falls, and whatnot in older adults. So moving on from the bowel, we have again very common issues which needs to be dealt, and people often report to us about sleep the lack of sleep. So as many of you must be aware, when people cross 60, their sleep requirement is shortened to less than 5 to 4 hours. People after their retirement want to sleep very lavishly. We cannot blame them, but then unfortunately God has created it in such a way that the sleep requirement decreases as we age. Somebody 60 plus, their total 24-hour sleep requirement is just 5 hours or 6 hours, and they might be having an afternoon nap for 1 hour. Don't rush to writing a sleeping tablet, because a sleeping tablet or benzodiazepine is probably even non-benzodiazepine, including solpidums, are probably the biggest harm you can do to older person who are at the risk of a fall otherwise as well. So find out whether they're satisfied. See whether they are having at least 5 hours of sleep altogether in 24 hours. Try to find whether there are OSA symptoms, daytime sleeping, snoring. Find more history from their partner as well. Find whether they are REM sleep disorders, whether they're sleep talking, whether they're enacting their dreams, because all this could be actually pointing to the evolution of a dementia syndrome or a Parkinsonism syndrome in the near future. So you can use few scales as well. And a lot of sleep hygiene techniques and non-pharmacological techniques, which can be discussed sometime later, are actually better than giving sleeping tablets. And please avoid tablets like, say, including beta blockers. Many physicians somehow don't realize that beta blockers can actually cause sleep deprivation. So find out medicines which can cause sleep deprivation, take it out, optimize, rather than rushing and giving them a sleeping pill as such. Moving on from sleep, Again, nutritional status. So at least two questions you should ask every older adult is whether you have loss of appetite, whether you have loss of weight, and if there is a significant loss of weight, because they're very prone to develop a cancer and a malignancy at that age. There could be other factors like depression, lack of availability of nutritious food, lack of someone who's willing to cook food for them. There could be issues with the dentition. There could be a lack of any diet or supplementary plan. Could be underlying issues like diabetes, heart failure. Try and see what is making them suffer from nutritional status, because maintaining adequate nutrition is the key to having a healthy older adult. From nutrition, as we move on, very common assessment which all of us do, but should very well focus on older adults, is to check for cataracts and vision issues. Because if you, as a primary doctor, identify a cataract and tell them to get it operated, many of them would be willing to do it. Rather than they running to some camps, you can actually pick it up by simple clinical examination. If possible, if you have the luxury, you can refer them for a fundus examination and IOP assessment as well. But check for near vision and far vision at least once a year. Please, I mean, like, you can just help these guys out by ensuring good vision, that they don't trip and fall somewhere and they see well for the rest of their life. From vision, something which is being very well neglected is hearing. So I go by hearing assessment by a simple thing that whenever the partner of the patient, like the husband tells that the wife is not listening to me, I mean, not listening to me in the other sense, in the sense that she cannot hear when I shout, or the wife tells that the husband doesn't hear, I take it for granted that there is some hearing issue, because the patient will always deny hearing issue. You can do a simple tuning fork assessment, you can do a whisper test, or something which I call now the mask test. I speak softly with the mask on, and if the patient understands, I give him a pass mark. So, I mean, you can try any of these methods and at least ensure that they have a proper hearing aid in place. And the way I encourage older people is, if you can wear a specs to see well, please don't hesitate to wear a hearing aid to hear well as well. So moving on from hearing, so the major headings are over. This is a functional capacity assessment, which probably you might not have a luxury to do in the OPD, unless of course you have a handheld dynamometer. The other one is timed get up and go test, where you ask a patient to get up from a chair, walk for 3 meters and come back and sit, where you see how fast the patient can do that and how well the patient can do that in terms of gait, instabilities, arm swing, using of hand to get up from the chair. All those things are being done. But then I'm just putting this for academic interest. If possible, if somebody is interested, you can read about it. Finally, whatever the patient's complaint should be addressed, because they might be complaining with vague complaints. And in our OPD in Annamalai during our rural posting during internship, we used to write Kaikal Kodachil syndrome, where people come with vague complaint, and then Vali Uzi and some Shakti Uzi, that means Uzi is Tamil for injections, you give them and bluff them and send them home. Please don't neglect their vague complaints, because vague complaints in older adults can open to newer dimensions. Even hidden malignancies are opened from very vague complaints which they have seek multiple doctors for. So record and address and see what you can do about the complaints as well. I need not stress about physical examination here, because as St. John's product, I believe all of us are kind of smart enough not to miss something in our clinical examination as well. So moving on, appropriate reference, appropriate investigation, because older adults don't want to have a battery of tests done on them. They are probably limited on budget, they're limited on time, they want a targeted approach. You will have to give them limited investigations. Taking care of older people, runs through and as a team always. You can never be a geriatric doctor by being yourself exemplary. You have to develop a team. So even in a rural hospital, you might not get these roles there. You might not have the luxury of getting a dietitian there, but you can train one of your nurses to give dietary advice. You can get somebody to have a little physiotherapy exposure in St. John's or Vellore or somewhere where they would be happy to train bits and pieces. And you can actually, have a better quality of life, because you as a doctor might not get time to address everything for a patient. I'm giving this as a food for thought kind of thing, where please let your team members train in these aspects, so that a complete team who can take care of older adults would be there in your OPDs as well. Last but not the least, very important to have family meetings about older adults. These days, you can use even information technology to connect people, or Zoom or Google Talk or WhatsApp, but get the family to know what is happening. Don't be happy that the older person who comes to you is happy, because a lot of litigations, a lot of acquisitions happen when you're dealing with older adults. You have to even ask the family members. So, when in case of an emergency, are you entrusting me or somebody else to make an emergency decision? Because in rural setting, when you have limited resources, whether to rush through referrals, whether to push through that patient to somewhere else, or to give supportive care, end of life care, all this becomes an issue. So be in touch with the family. Don't be happy with meeting the grandpa and grandma who comes to your home, I mean, to your OPD. Try and see who else is behind them. Connect them over phone. Talk once in a while. Tell them what they are going through. And this will help even the family members realize what are the troubles their parents are going through in their older age, at least. So yes, so finally, that is whole about having a comprehensive geriatric assessment very quickly. And I was rushing through. I know all of these slides individually are separate lectures and separate matters of discussion, but I think we would wind up with there. And in geriatric care, like Nitin said, rural service is where I got my instinct or my motivation to do MD geriatrics, which I completely enjoy and practice even now. And rural service, I hope, would open up a new thought process in your mind where you would be seeing a particular type of patients, and you also would be able to identify, just like how I did, on what you want to do in your life. And probably that's your true calling, and that will take you to different heights if you can correctly, I mean, get it through your rural service. Thank you.
Thank you, Gino, for that very comprehensive talk on comprehensive geriatric assessment as such. And care of the elderly is a challenge both in any hospital, be it in the city or in the rural area. And most patients of quite a few bond centers are in the rural age group as such. So the first question which has come in is an elderly female who is a known case of diabetic with severe left knee pain, described mostly like neuropathic pain, giving painkillers but very minimally pain relief. How to proceed for further management? So basically, diabetic, severe left knee pain on painkillers. I don't have the what painkillers she's on. How would you approach pain in a geriatric patient?
Common complaint is a knee pain. Probably most likely diagnosis there could be osteoarthritis itself. Again, as you know, probably the best management for osteoarthritis, like my surgery friends would agree, would be to have a knee replacement. But we might not be in a position to afford or refer for a knee replacement when we are dealing with older patients. So I give adequate pain relief usually using paracetamol, using the step ladder. After paracetamol, you can always use a little bit of NSAIDs once in a while, but ensure that your patient doesn't abuse and understand that NSAIDs are my pain relief medicines. Obviously, if you have the luxury of giving intra-articular steroids, you could get the help of a orthopedician, or some of us who were trained during our bond time to give intra-articulars can attempt that as well. But again, it's a short-term relief. The key there would be to actually guide them through a very good physio rehabilitation process, because strengthening the hamstrings, strengthening and giving them assistive devices which will help them relieve pain and walk more. Because as you know, the usual way of things is, once you have the more knee pain, more swelling, they will sit. The more they sit, the knee pain and swelling worsens, more stiff it becomes, the OA worsens. So ensuring good mobility, safe mobility,
I think we sort of lost Gino there temporarily. So essentially, just to follow up on that question, which one of the bonders had messaged in our group, is first find out what is the cause of the knee pain. Is it an orthopedic cause, or is it because a neuropathic cause? Now, if it's an orthopedic cause because of osteoarthritis, as Gino was telling, very important that along with pain medicines, it's important that you make sure that good physiotherapy, good mobilization, and good rehab is added to it. And of course, if it's neuropathic pain, then the management is different. So it's very important to find out what is the cause of pain. Yeah,
one thing
please
else,
go ahead. I
again,
was
like,
covering up for you.
yeah, sure. Like Nitin said, see, we just assume that it is a OA straight away, and that's exactly what happens with geriatrics, because you tend to label their problems. always, like again, I would quote my professor, Dr. Sureka, everything in geriatrics is multifactorial. Somebody tells you about a pain, the same pain could be because of two, three different reasons, and try and see what best you can do for everything. And that would be the way to proceed, I would say.
Right, Gino, there's a question from Dr. Tijo, which essentially you would be able to answer given your experience, even in a geriatric center in your rural posting as such, that if a patient complains of bradykinesia, instability, and action tremor presents with progressive worsening, should we refer him to a higher center, or can the rural doctor start him off on Syndopa?
I'm happy Tijo is asking this because two things. Tijo is working in my bond center and Tijo is inclined to geriatrics as well. So I'm very proud that my bond center is bringing up new geriatricians. So again, yeah, Tijo's doubt. See, recognizing and managing a progressive extrapyramidal syndrome in the resource poor setting is probably something which we can do. Differentiating a typical Parkinsonism and atypical Parkinsonism, yes, any graduate can actually try and find out and differentiate. But if you have the resource of utilizing a neurologist or a geriatrician around, I would say please do that for one shot, because many of the times Parkinsonism syndromes have overlaps and they will be actually phenotypically appearing the same. I mean, like it might appear that there is a bradykinesia and a tremor there, but yes, it could be from setting to setting. And I would say no harm in trying a half Syndopa and seeing whether the patient is Syndopa responsive or not. If somebody is not Syndopa responsive, please refer them. Because somebody is not Syndopa responsive, it is definitely going to be atypical Parkinsonism, and that needs a neurologist or a geriatrician to probably manage it further. But again, it would be very nice if the rural doctors actually manage it, because once they become more dependent on Parkinsonism, more dependent and more bedbound, they would be probably just going to the rural doctor only. They won't be having the luxury to walk into a city-based tertiary care hospital. So I think the more we read, more we experience, and that we would be able to manage it ourselves.
Right. Thank you so much, Dr. Gino, for that wonderful talk on a much needed subject, and probably one of the most neglected and underrated subjects on how to care for the elderly in a rural setup. And as India's demographics keeps changing, the need for geriatrics goes on improving. There's one last question which I want you to answer very shortly and briefly, which is that is there any distance education program in geriatrics that can be done along with rural service? And again, like I said, this is a big need.
Yes, there is. There are. In fact, one is from CMC. I would recommend the CMC program because it's very well structured. The CMC program is a 1-year distance education program. Any MBBS graduate can apply for that. It is a PG diploma in geriatrics. It's called. The course fees is roughly around 50,000, but it's a 1-year course with 2 contact programs in CMC. A lot of well curated training modules are there. Second program is one by IGNOU, Indira Gandhi National Open University, which many of our senior doctors have taken. But again, it's not essentially run by geriatricians, so I wouldn't recommend you to do that. The third program is run by GSI, Geriatric Society of India. Again, the lacunae there, it is not run by a medical college. So among the 3 programs, CMC program is very open. There are 50 seats every year, and Johnites are always given a preference after CMC for that program. So any Johnite who won't apply can definitely go ahead and apply. You can do it during your bond time. It will finish in 1 year.
Right. Thank you so much, Dr. Gino, for that wonderful talk. And really, as one of the co-founders of the Johnite Academic WhatsApp group, and for taking the lead in supporting rural bonders through the ages, thank you for taking time of your busy schedule and addressing the bonders. Thank you so much again.
Thank you, Nitin. Hi, Dr. Sudhi.
Right. It's my privilege to next introduce our speaker, Dr. Shruti Kulkarni, who is the Associate Professor in the Department of Medicine from St. John's Medical College. Very, very passionate about teaching, and that's something we all as postgraduates have experienced on our rounds. Her meticulousness to details, and also, more importantly, how to approach symptoms is something that we learned on rounds with her. And perhaps no better person than to take this topic on approach to palpitations. In fact, most rural bonders in the WhatsApp group start messaging, patient came with palpitation, this is the ECG, what do we do? But it goes beyond that. There is a lot of art in taking the history of palpitation beyond the interpretations of ECG findings. So over to you, Dr. Shruti. I thank you because ma'am was slightly off color and not doing well, but she still has the passion and the energy to come out today and address all the bonders and the doctors working in rural service as such. Dr. Shruti, we are not able to hear you. No, we are still not able to hear you. No, still we are still having. If you could click on settings and click on audio. No, no. Could you click on settings? Click on audio. No, we are not still able to hear you as such. Can you? No, we are not. We are not able to hear you. We apologize for the technical glitch. We will start soon as we.
Can you hear me now?
Yeah, perfect. We can hear you now. We can hear you now. We can hear you now.
Okay.
Yeah, perfect. You have control over the. You have control over the slides. You can start off.
Sure. Thank you. Thank you. I hope it's audible now.
Yes, it's
Better now.
audible.
Thank
Yeah.
you. Okay. Well, first of all, thank you so much, Nitin. Thank you, the Alumni Association, for giving me this opportunity. As the Nitin said, sorry, I'm a little unwell, but I'll try my best to make you understand the way I have understood and the difficulties I have found for as simple and common a topic as palpitations. Um, So the objectives for today's talk will be to know what palpitations are, what is the pathophysiology underlying this very common symptom, what are the causes of palpitations, how do we approach and manage patients with palpitations. Now, the definition is very simple. All of us know that whenever there is an unpleasant awareness of one's own heartbeat, it's called palpitation. Simple. Like you become aware of your own heartbeat, that's palpitation. It's a very subjective symptom. There is no objective way of figuring it out. And generally, it's described in a very different fashion. Some people say it's like thumping on the chest, pounding on the chest, a rapid fluttering, flip flop. Or some patients directly use the word palpitations if they have experienced it earlier and they know what it means. Now, What does it mean? Does it mean it's a heart disease? Not necessarily. It may or may not be a heart disease, which means it's maybe cardiac or non-cardiac in origin. But having said that, the most common cause of palpitations are cardiac in origin. Again, the degree of palpitations doesn't correspond to the severity of the heart disease, or for that matter, severity of any disease. It doesn't mean that if a patient has more palpitations, that means he has more disease, less palpitations is less disease. Now, the pathophysiology, oh, I don't know, there's some change that has occurred in the slides. Anyway, sorry for that typo and sorry for the font size. So, the pathophysiology includes whenever there's a change in the rate, the heart rate, whenever there's change in the rhythm of the heart, or whenever there's an augmentation of the myocardial contractility, which is a very forceful contraction without even the change in the rate or the rhythm, the person experiences palpitations. Now, as I said, even though palpitations can be cardiac or non-cardiac, most palpitations are cardiac in origin, followed by the psychiatric causes and other miscellaneous causes, which are still very, very important, the miscellaneous causes, because most of them are medical causes, which I'm interested in also. Life-threatening causes of palpitations are mostly cardiac in origin. So I'll come to the cardiac causes to begin with. I do not want you to remember it like the way I've put up here. I'll tell you what it means. So one, I said whenever there's a change in the rate, the heart rate, it can cause palpitations. So the change in the rate, we know that the normal heart rate is between 60 to 100. Whenever there's a change beyond the physiological limits, less than 60, which is called bradycardia, more than 100 beats per minute, which is called tachycardia, both bradycardia and tachycardia can cause palpitations. That's what I want you to remember to begin with. One. Second, whenever there's a change in the rhythm of the heart, again, the rhythm may be faster in nature when we say there is an alteration in the rhythm, plus it is associated with a higher heart rate when we call it tachyarrhythmias, or there is a change in the rhythm and associated with a lower heart rate when we call it as bradyarrhythmias. So both bradyarrhythmia and tachyarrhythmia can cause palpitations. So what's the third one that I said? Augmentation of myocardial contractility, which is a forceful contraction that can occur in conditions wherein the left ventricle has to pump against a higher resistance, which can happen one with hypertension, two in aortic stenosis. So whenever there is a change in either the rate or rhythm or the myocardial contractility, or let me put it as augmentation of the myocardial contractility, patients will come to you saying they have palpitations. Now, when it comes to arrhythmias, all of us get scared because we don't know how to pick it up. We don't know how to identify them. But what I want you to remember is that rule out the first one and the last one first when a patient comes to you, and then I'll tell you how to approach these arrhythmias with a very simple way of looking at it. So one of them, as I said, is either a bradyarrhythmia or a tachyarrhythmia. There's also a condition wherein the rate may not change, and you could have what are known as premature ventricular or atrial contractions. So in that case, the rate remains the same, but because there is a premature contraction, so the SA node starts the automaticity, and then that's followed through your to the AV node, and from the AV node to the ventricles to the bundle of His. Now, whenever the rate remains the same, but then there is a new foci wherein the automaticity takes over, and instead of the SA node, that generates another impulse, which gets captured, because it's not in the refractory period. You will note that there is a premature atrial contraction or a premature ventricular contraction, which are bizarre looking, both of them. Now, what are the other causes? This is just to name them. Don't get scared looking at these names, that there are something called supraventricular and ventricular causes. When I say supraventricular causes, it's basically about the AV node, which is controlled only by the atria, and the AV node where everything gets kind of delayed or the refractory period takes place there, kind of make sure that the ventricular activity remains normal. So that becomes supraventricular. There can be problem anywhere. It could be in the SA node, it could be in the conduction from the SA node to AV node. Now there are ventricular arrhythmias, which by the as the name says, it's ventricular in origin. So it could be ventricular tachycardia or ventricular arrhythmias. So we have supraventricular and ventricular. Another thing that I want to tell you, that apart from the arrhythmia, apart from the change in the cardiac rhythm, as I said, the rate changes. One of the important things we need to remember for palpitations in cardiac causes is heart failure, because it's a very common symptom and the diagnosis that we see in our everyday lives. The other are the psychiatric causes. Psychiatric causes, I'll tell you how to approach them, and I can't talk to you about how to approach. I'm just telling you now the etiologies of what all can cause palpitations: cardiac, psychiatric, and of my interest, apart from cardiac, are the medical causes. Now, all of us know that when you try to, catch a bus, train, and when you're late for the class, and when you're like running, and then you reach the class, you're like, why are you panting like this? So at the same time, you will have palpitations because it's a subjective symptom. I won't know that, only you know that you're having palpitations. So there are some physiological causes, which is just simple exercises. Drinking a lot of coffee, caffeine can cause palpitations. Pregnancy, because these are all physiological causes where you can have palpitations. What are the pathological causes? Well, common ones again. When somebody comes to you with fever, whenever you see a patient and then you see that they're having palpitations, the first thing we check in the OPD or in the wards is try and see if they have fever. So whenever the temperature raises, we know that with every 1 degree raise in 1 degree Celsius raise in temperature, the heart rate goes up by 10 beats. So whenever the patient has fever, we know that the patients can have tachycardia. To that matter, even a little tachypnea. So does the patient have fever, or they could be in frank sepsis, which is why the pulse rate of more than 100 that you see on them is just part of a systemic inflammatory response syndrome, which is causing tachycardia. The other important causes are endocrine causes, which are thyrotoxicosis, hypoglycemia, pheochromocytoma. So strangely, most often than not, hypoglycemia, even though can manifest with neurological symptoms, can also have these autonomic causes, autonomic symptoms. So patients with hypoglycemia, one may come and tell you that, I felt a little dizzy, I felt a little tired, I didn't know what was happening. I was almost about to lose consciousness. But you'll have another set of people who will come and tell you that I started sweating, I started having some chest discomfort, there were palpitations. These are the neurohumoral responses to hypoglycemia. So palpitations can happen in hypoglycemia as well. Another set of people who are young but who come to you with palpitations are people who are on sympathomimetics, the ones who abuse cocaine, smoking, alcohol, and the other elderly or non-elderly who are on either beta agonists or have beta blocker withdrawal. I want to just take a minute and stress on this fact of beta agonist and beta blocker withdrawal. Whenever you see patients who with bronchial asthma or COPD taking inhalers, and if you see them in the ear OPDs, you can see that they may have mild tremors. You may also notice that their pulse rate, if not more than 100, is usually in the 90s. So the pulse rate may be in 90s or more than 100. The first thing you should ask them is if they are on beta agonists. So the most common one we give, the inhalers that you give, Astelin, Diolin, which is a combination of Astelin and Ipravent, can cause palpitations because it's a beta agonist causing a sympathomimetic effect. The other thing on beta blocker withdrawal is that, if somebody is on a beta blocker, it could be anything, metoprolol, bisoprolol, whatever they're taking already for either hypertension or for their cardiac disease, and they come to you in failure. Let's say they've come to you in heart failure, or they've come to you and then you check the blood pressure to be low. Do not stop the beta blocker suddenly. Sudden stopping of beta blocker can not just cause palpitations, but it can worsen the failure. So basically, when you are giving them beta blockers, the beta blocker receptors are all down regulated. Immediate stopping causes upregulation, and the beta agonist activity, or sympathomimetic activity, can make things very worse. What are the other causes? I've already mentioned, I've again put it on this slide, heart failure, because I never want you to miss heart failure as one of the causes which can cause palpitations, because it's quite ignored. We always think that it could be an arrhythmia. The other thing is severe anemia, which can cause palpitations. So how do you approach? So I want to keep it simple. How do I approach? I'll only do three things. One, I'll take a detailed history. Two, I'll do physical examination. Three, I want ECG. All three will be available in your rural bond center. The 12-lead ECG is available everywhere. Now, in fact, they're coming up with these, you know, the non-invasive methods of checking the ECG and all that. So it's very simple. So what is the important thing that I take in history? One, if palpitations are the only presenting complaint, then the history holds good that my focus is only on palpitations. If the presenting complaint has palpitations and few other symptoms, I'm going to take palpitations in conjunction with the association of the other symptoms. Now, let's say a patient has come only with palpitations. As with any history, my interest is in one, age of the patient, two, gender. So these two are extremely important for me to make my differential diagnosis. So age, gender, and then start asking them about the details of the palpitations. So few things I ask them is, okay, for how long have you been having palpitations? So I want to know if it's acute or chronic in nature. One. Two, how is the onset of palpitations? Is it sudden onset or gradual onset? Sudden onset is they don't even know. They're going about their own work. They're working, they're studying, they could be doing anything, they're lying down for that matter. And all of a sudden they feel this thumping, thud, flip, skipping a beat kind of a sensation. And then it just disappears just like that, like the way it appeared. So it's sudden onset, sudden offset. Gradual usually happens with exertion. Gradual can happen at rest also, but usually, whenever you ask them when does it happen, they say with exertion, when they try to walk, when they try to do extra exercise that they're not used to. It starts off gradually, just like the way it happens physiologically for you and me. When we exercise, it's gradual onset, gradual offset. So it starts, then the tempo increases, reaches its peak, and then either the patient rests, they know that the exercise is making it worse, they rest, and then there's a gradual offset. Then over the next few seconds or minutes, they start feeling that it's coming down and then it stops. I need this history. Why? I need this history because sudden onset, sudden offset is usually arrhythmogenic in nature. So cardiac arrhythmias cause sudden onset and sudden offset of palpitations. The heart is going about its physiological automaticity, conduction of the electrical impulses, and whenever there is an aberrant conduction or aberrant generation of an electrical impulse, it's very sudden, and for no reason the electrical stimulus stops all of a sudden. So that's the importance of sudden onset and offset. What about gradual onset and offset? Gradual onset and offset, usually there is an underlying structural heart disease. It could be as simple as your ischemic heart disease. Remember, under NYHA, the New York Heart Association, we ask you what are the four symptoms. What are the four symptoms? We ask you to classify the NYHA. One of them is palpitations. So when does it occur? Is it when you do extra work? Is it when you do your regular work? Is it just less than regular work, or is it at rest? So this gradual onset offset will tell me that one, the patient could be having ischemic heart disease, or it could be a structural heart disease like mitral valve prolapse, which is a very common condition and a very common symptom as well in people with MVP, mitral valve prolapse, to have palpitations. Or it could be a rheumatic heart disease, patients with MSMR. So how does palpitations occur when there is mitral stenosis? Whenever there is mitral stenosis, the left atrium enlarges, So whenever the left atrium enlarges, so there is this array of cells which are arranged very neatly, nicely. They all work together as a syncytium. And whenever there is a pulling, because there's dilatation of the right atrium, there is a disarray, which is the arrangement of the cells is kind of lost and the syncytium is lost and it generates an aberrant impulse and it causes atrial fibrillation. So in mitral stenosis, the cause of palpitations is atrial fibrillation, whereas in mitral regurgitation, it's just the extra volume of blood which needs to be ejected out, which causes, there is a regurgitant jet, there's a volume overload which causes palpitations, which is gradual in onset, gradual in offset, because people with MR have to do certain activity for them to have those palpitations. Unlike in mitral stenosis, if it's because of AF, it's sudden onset and sudden offset. Okay, so apart from that, we are looking at what are the triggers? Did it happen after drinking coffee, tea? And what are the associated symptoms? Associated symptoms may be because of the underlying heart disease, like breathlessness, chest pain, dizziness, and syncope. The systems review here is important. As I said, even if they've presented to you only with palpitations, I'm going to ask them about other symptoms to see if there is any other system involved or if there is the miscellaneous cause which is causing the palpitations. What all are you going to ask them? One, blood loss. If it's anemia causing palpitations, I'm going to ask them if they're losing blood anywhere. Two, I'm going to ask them if they're losing weight, if they have diarrhea, if they have sweating, because I'm interested in thyrotoxicosis. I want to know if they have diabetes and what medications they are on. Past history, of course, the important one is to know whether they've had past history of congenital heart disease or if they have ischemic heart disease, rheumatic heart disease, or if they've undergone any cardiac surgeries. Also, past history will include diabetes, hypertension. If they're on treatment for thyroid disorders, it could even be hypothyroidism. But I want to know if they are on treatment for thyroid disorders. Medication history, because a lot of these over-the-counter drugs, like nasal decongestants, which includes amphetamine and these drugs that have the beta agonists in them can cause palpitations. Personal history for smoking, alcohol, use of illicit drugs. What are the red flags? Now, the person has come. I know if he's young or old. I know whether they're male or female. I've taken the details of the palpitations. I've taken the past history. I've taken personal history. I know what's happening to them. But did they give me more history when I asked them, which is there was syncope? Then it's a red flag for me. That means I cannot take this lightly. If they had chest pain or breathlessness, it was new onset. They never had it. So, and if they have a family history of sudden death, family history of sudden death is very important because this person has a chance of having the same. What will I do in my physical examination? Of course, start with pulse. I'm starting with vital signs here and not general examination because, as I said, the life-threatening palpitations occur from cardiac causes. So my interest is in to immediately check the vital signs and then I'm going to do the general physical examination. So pulse, why do I want? I want to know if they have bradycardia, tachycardia. Blood pressure, again, hypotension. In fact, you can check for orthostatic tachycardia and orthostatic hypotension, which is they do not have tachycardia or hypotension when they're lying down, but when you make them stand, you can induce it. They can have it. Respiratory rate, I want to know if they have bradypnea or tachypnea because it is associated with the underlying condition. And JVP. JVP, because as I said again, heart failure, anemia, thyrotoxicosis, all these can cause elevation in the JVP. What am I going to look for? Head to toe examination, one pallor, two all signs of hyperthyroidism. You know everything, head to toe, what all you're supposed to look for, and then do the cardiac examination. So basically, I've tried to capture the cause of palpitation just by detailed history. In fact, physical examination of vitals will give me enough knowledge of what to expect. But on cardiac auscultation, if you see that the rate is high, and it's irregular. For example, if you get an irregularly irregular pulse beat, and then you go and check the heart rate, and there's a difference between the heart rate and the pulse rate, and you heard an extra sound, you heard an extra click, you heard murmurs, that means they have a structural underlying heart disease, which is enough for them to have palpitations. So I've taken my history, I've done my examination. Now I want an ECG done. See, more often than not, whenever you see people with palpitations in the OPD, they won't have palpitations when they're sitting and talking to you. They come to you with history of palpitations, that I have had palpitations for the last 2 months. So usually our investigations are all in this so-called normal period between the two palpitation episodes. But nonetheless, it's very important to pick up things. So I've just put a normal ECG. So this is how it should look. So you have the P waves followed by the QRS and the T. Now this is the rhythm that I expect in every beat to occur, because you have the atrial depolarization, repolarization, ventricular depolarization, repolarization. So basically this is the cycle, and they are in a loop or a shuffle that they go as PQRST, PQRST. So this is how it needs to go. Now, any change in this, don't worry about what the change is. As long as you notice any change, all ECG should look like this. If you notice any change, that means that it's an abnormal ECG. That's all I want you to pick up to begin with. Now, the important one that you need to know about is AF. Sorry, this is what I want you to know. The rest of them, even if you don't know, it's okay, because you can always send us the ECGs or refer them. You will have time. But whenever a patient is in AF, you may not have time, and you might have to stabilize them before you send them elsewhere. So what happens in atrial fibrillation? As the name says, the atria are fibrillating. It's not that the left ventricle or the right ventricle, they contract together. So both the atria are fibrillating. So obviously, there's hardly any impulse that's getting generated which is valid enough for it to reach the AV node and pass through the AV node and ask the ventricles to contract. So you will not have a P wave because it's fibrillating. The P waves come from the SA node, the automatic impulse generation. You will not see a P wave, but occasionally if you do see a P wave, it's okay, it's normal. So one of the impulses came from the SA node. And then atrial fibrillation is problem with the atria, it's supraventricular. So from the AV node below, everything is normal. So you will always have a normal looking QRS complex. A normal looking QRS complex is QRST, which is very narrow like this. Within 3 small boxes, you have the QRS here. So the problem always is in this region in atrial fibrillation, which is you will not find a P wave, and the rate is irregularly irregular. So you have one QRS here, followed by 2 boxes QRS, 2.5 boxes, and then 2 boxes. And look at this, there are 4 boxes apart. So you have an irregularly irregular QRS, R waves rather, and these are the fibrillatory waves. So this is what you get in atrial fibrillation. Okay, so I'm just because I named all of them, I'm showing you the ECG of all of them. 1, atrial tachycardia. 2, atrial fibrillation. You can even have flutter waves. So atrial flutter, the difference is that you will have a regular QRS complex, and then instead of these fibrillatory waves, you will have a sawtooth appearing waves. It's called an atrial flutter. So atrial tachycardia, atrial flutter, atrial fibrillation, the common ones and the important ones. What about the ventricular causes? Okay, of course, let me finish the atrial one. So, and the supraventricular tachycardia. Supraventricular tachycardia, very regularly normal appearing PQRST, but what happens is as the rate reduces, the P comes closer to the T, and the P and T may look almost like a single wave. So this is supraventricular tachycardia. This is a scary looking ECG. If you see this, then you must also be scared. This is ventricular tachycardia. There are no P waves at all here. There is no P. We are only looking at the ventricular activity, and there is tachycardia, which is the heart rate is more than 100. So these are just the QRS, which are bizarre looking. So you will have the ventricular activation and ventricular tachycardia, which is a life-threatening condition. So I told you, so I kind of dealt more with tachyarrhythmias, because tachyarrhythmias are, again, among the arrhythmias, tachyarrhythmias are the more common cause of palpitations than bradyarrhythmias or blocks. Well, type 2 and type 3 second degree and third degree atrioventricular blocks can also cause palpitations. I'm interested in complete heart block again because this may require urgent referral and urgent management. So, to put it in simple words, you keep looking at the ECG. So, basically, what happens in third degree AV block is that the AV block has completely blocked the conductions from the atria. So, the atria is generating impulses and contracting at its own pace, and the ventricles are generating their own impulses, which are not the conducted impulses from the atria, and contracting at its own pace. So they basically disengaged. The atria is contracting when it wants, and the ventricle is contracting when it wants. So occasionally, once in a while, it may so happen that the atria contracts followed by the ventricular contraction. So in that case, it may appear like PQRST. Otherwise, you have P wave coming on its own term and the QRS coming on its own term. So there is no relationship between PQRST. No, with this, it's in a rural bond, or if I'm sitting in a resource poor setting, this should be enough for me to make a diagnosis. Having taken a detailed history, done a physical examination and ECG, the 12 lead ECG is what helps me determine if I have to do any further investigation. Any abnormal ECG that's picked up immediately goes for further detailed investigation. That doesn't mean that a patient with normal ECG does not have a heart disease, but basically, I probably will get some time and can do my other tests and figure out whether he requires immediate attention or I have a lot of time in hand. So with this, I know whether it's cardiac or non-cardiac in origin. What are the tests that I will do when ECG is normal? I will go ahead and do the test to find out medical causes, which is the non-cardiac causes, whether the patient has anemia, has got hyperthyroidism, has got hypoglycemia, and then if he has fever, look for the focus of infection. The TFT is important not just to pick up hyperthyroidism, the or thyrotoxicosis. The TFT is important also because whenever patients take treatment for hypothyroidism, when they are on levothyroxine, sometimes they just continue to take without any further tests done. So, an excess use of levothyroxine will push them from hypothyroid state to hyperthyroid state. So, that's why it's important for me to know if they were hypothyroid and they're excessively taking their medicines. So, how do you, now that I know in what settings I have to suspect palpitations, I've done my ECG, I will know what to do with these patients, provided I know that they're hemodynamically stable. Any hemodynamic instability, which is tachycardia, continuous, persisting, hypotension, which of course cannot be managed with just IV fluids. They are sick looking, they are tachypneic, the hemodynamic instability, there is absolutely no time, there has to be an immediate referral. I put this slide so that you know what you can do in the setting where you don't have a cardiologist, you don't have a Holter, you don't have the cardioversion defibrillator facility. What do I do? If you find an isolated premature atrial contraction, which is a different looking or a bizarre looking P wave as compared to the normal looking P waves, it's just once in a while here and there. So that's called a premature atrial contraction. Similarly, if you see a premature ventricular contraction, patients are hemodynamically stable. You don't have to do anything. You just have to reassure them because more often PACs and PVCs never lead to serious cardiac outcomes. If you see a patient with SVT, if you think you picked up SVT on the ECG, or you think that it could be SVT from whatever history examination that you got, you could tell him to use Valsalva maneuver to immediately terminate the SVT. So if they're somewhere in the market, they're somewhere else where they can't go to the doctor, you can tell them to hold their breath, close the nose and the mouth and try to blow out. That's one thing they could do. Or the simple thing that they could do is do a carotid massage. So they won't know where the carotid is. So obviously you can just tell them, take your hand and keep it on the side of the neck and then just massage it. So carotid massage, so that there is a vagal stimulation, a vagal maneuver, which reduces the heart rate. Atrial fibrillation, if you think that the patient is hemodynamically stable. Obviously, the pulse rate will be more than 100, but the blood pressure is normal. In that case, you can start them on a beta blocker. You can, that's called a rate control drug or diazepam. The rate control drug is amiodarone, and you have to give them anticoagulants to prevent embolism. If somebody has atrial fibrillation, they can develop clots in the heart, which can then embolize. If you refer them, the reference will be to obviously get an implantable devices done for cardioversions. So we do not do that. We refer them for medical surgical treatment. And then in the treatment itself, we look at their medication review and change if required, and then ask them to stop smoking, drinking, and excess caffeine. I'll leave it here because you can go through this. This is the same as that I just spoke to you about. To conclude, one, palpitations are common symptom. Most of them are benign. I'll take a thorough history, do an examination, do a 12-lead ECG. It gives me a clue whether it's cardiac or non-cardiac in origin. If it's cardiac in origin, I'll get an echo done. Why? It will tell me whether patient has mitral valve prolapse. It will tell me whether patient has got ischemic heart disease. They could have what is called as a regional wall motion abnormality, the part of the myocardium which has undergone infarction ischemia, which is not working. Or I will know whether they have a rheumatic heart disease, which is MSMR or aortic stenosis. What will I do next? There are other facilities, if available in your own center like Holter, you can put them on Holter, otherwise refer them. So whatever can be managed in your center can easily be managed with just history, examination, and a 12-lead ECG. Thank you. Nitin, I hope I didn't take too much time. I
Yeah,
couldn't.
thank you, Dr. Shruti, for that wonderful talk. Hopefully, the doctors serving in rural area will themselves not get palpitation when dealing with patients of palpitation, because it's very, very vague, and you always need to have the skill and the art to differentiate between what is serious and what is not serious. So, we have a question from Sangalp, who asks how to deal with patients who are anxious and are complaining of palpitations even after being started on anxiolytics, and behavioral therapy is ongoing.
Well, if you're that certain that it is purely an anxiety disorder or a panic disorder causing palpitations, and if they're not better with anxiolytics or CBT, obviously it needs referral to a psychiatrist so that they can put them on other treatment. But even again, that's another thing. Good you brought this up. Again, just because somebody has got anxiety or an anxiety disorder, every palpitation is not always a panic attack. Please make sure that you at least do an ECG to make sure that if they're having palpitations when they come to you and then when they're talking to you, just do an ECG to make sure that they don't have an underlying heart disease.
And more importantly, in the what they have, one of the rural bonders has messaged me is that patients come with palpitations, but sometimes they do not come back for follow up. When is it, or what are, you did mention in the talk, and I don't want it to be redundant, but what are the red flag signs you would take in the history to tell them, look, do a ECG right away, do not delay?
Right. Whenever you see elderly people, diabetes, hypertension, ischemic heart disease, or you know that the patient has an underlying rheumatic heart disease, or even if you don't know, if they come to you saying that palpitations were associated with syncope or near syncope, palpitations were associated with chest pain, which could be angina. So you have to ask them how long did the chest pain last and what happened to the chest pain after a period of time. So whenever it's associated with angina and syncope, it's a red flag. You have to evaluate compulsorily for an underlying structural heart disease, and the palpitations can be serious. Three, whenever as you talk to them, you see that they're not having palpitations, but their heart rate is more than 100. So they don't currently have palpitations, but then you pick up a tachycardia, get an ECG done.
Right. So, oh, fantastic. So, red flag signs: syncope, chest pain, breathlessness associated with palpitation. Get an ECG and do the evaluation immediately as such. Thank you so much for that wonderful talk and presentation. Beautifully covered all the points, and more importantly, just don't do a ECG. It is very important to take the history in detail and also particularly look in a rural setup for the thyroid and hemoglobin to make sure it's not a systemic disorder which is causing palpitation. Thank you so much, Dr. Shruti, for taking time off and also when you were slightly unwell for covering the talk on palpitations very well. Right, we now come to the last talk of the evening before we move into the interactive session. And I'm very fortunate to be joined by Dr. Pradeep. He's a consultant general surgeon in Manali in Lady Wellington Hospital. Tremendous experience in rural areas, and this is one topic which most doctors in rural service find it difficult to manage, and that's essentially how do you manage surgical emergencies as such, when do you refer, when do you operate as such. So it's my privilege to invite Dr. Pradeep. After Dr. Pradeep's talk, we will be joined by people who are actually doing their rural service right now to share their interactions and to share their perspectives and reflections as such. Dr. Pradeep, all yours.
Okay. Good evening, everybody. I hope I'm audible. Please, I
Yeah,
hope this is
yeah,
an
perfect.
interactive session. I want you guys to interact with me. So, I'll be talking about the management of surgical emergencies. I'm working as a general surgery consultant in a rural hospital in Himachal Pradesh. Prior to this, I did my residency in CMC Vellore, and before that, I also worked as a junior medical officer, just like you guys, for 2 years in a rural setup. So, management of surgical emergencies is something I've been dealing with for some time now. It's still, I'm also learning every day as I see new emergencies. I just want to give you a few case scenarios that gets you familiar with what are the things that you should be seeing in patients, what to look for, and how to go about it. Okay, let's start. So, these are the common case scenarios that you do see, and we'll start off with a few. So the whole story. So Mr. X presented with a history of abdominal pain for 6 days. He was well 6 days ago, had sudden onset excruciating pain in his upper abdomen, later progressed to involve his entire abdomen. He was admitted in a local clinic for 5 days, managed with analgesics and IV fluids. So when he came to us, he came with his pulse rate is 130, his blood pressure was 70 by 50, saturation was 90. General examination, he had hypocrite's face, severely dehydrated. His abdomen, they had board-like rigidity over his entire abdomen. His hernial orifices were intact, and he had absent bowel sounds. So, as you can see, this is a gentleman who's presented in shock. He's peritonitic, obviously. Hippocrates' face is something that you don't normally see in general surgical emergencies. You generally see it in chronic debilitating diseases when they're on the brink of death. But as S. Das says in our manual for clinical surgery, you see it in peritonitis who are on the brink of death. So, diagnosis, investigations, and management. If anyone wants, you can always put in your inputs in the chat. I'll be looking at them. So, I want you to remember that diagnosis, investigations, and management all go hand in hand, especially when you're seeing a sick patient. So, here you have a young gentleman who's peritonitic and is in class 3 shock. We don't want to like slow down, do the investigations, and then start your management. It should all happen side by side. So, start off with the vitals whenever you present. That helps a lot. So start off with 2 wide bore IV cannulae, bolus crystalloids, give empirical IV antibiotics, take bloods at the same time for your CBC, creat, electrolytes, ABG if you are clinically indicated. Don't send a sick patient for complex imaging. No, this is somebody who should not be sitting directly in the CT room. It's a shame to have deaths in the radiology department, and these do things happen. So always see the patient with a fresh perspective. But as I told you earlier, he's already been admitted for 5 days in an outside center. So always review his old investigation. So while I was waiting for his bloods to come, I looked at his old X-rays. So he had an X-ray. I don't know if this is visible. I don't know if it's clear for you guys, but he had an X-ray from 3-4 days before, prior to presentation. It's an erect X-ray of the abdomen. As you can see, there are air fluid levels, but there is also a hint of pneumoperitoneum. There's air under the diaphragm. This is a surgical emergency. This is something that should have been operated right then. Then 2 days later, for whatever reason, they've repeated its X-ray of the abdomen, again erect. There are also multiple air fluid levels, tiny other air fluid levels, but there is clear pneumoperitoneum here. Okay, so obviously, I've already explained the X-ray. What X-ray would you do if you see Mr. X in the casualty? So what I would do is I would get a chest X-ray erect of the patient. See, this is a beautiful X-ray. It's an inspiratory film. You can see two intercostal spaces above the clavicle, but the focus is the diaphragm. You see, there's the domes of the diaphragm are lifted. There's pneumoperitoneum. This is something I do not want you guys to miss, and you will definitely see a few in your rural postings. So Mr. X was taken up for laparotomy. We noted that we bolused him with crystalloids. After that, he continued to hypotense. We started inotropes. We kept an NG, we kept a UCAT, and then we decompressed him, corrected his hypokalemia, and then we took him to OT. So in introp, we saw peptic ulcer perforation, B1. We did an omental patch repair. To cut short the surgery duration, we did a through and through closure, and we put drains, washed out, and we came out. Another thing to note over here is that whenever you see surgical patients following up with you, please don't remove off sutures. For example, this is through and through sutures. This is to cut short the operating time because he was on inotropes and sick. These sutures were to be removed after 21 days. Don't remove them after 7 days. So always consult a surgeon who has operated before you remove drains. Also drains, sometimes we do feeding procedures. So always consult a surgeon before you remove drains, because otherwise you may create a surgical emergency. See, 4 liters of bile. We had to take a Euro buckets to fill up the bile that was coming out of his abdomen. Something that could have been corrected earlier. Stones can kill. This is another case scenario. Mrs. Y, 45-year-old lady, diabetic on OHAS, presented with abdominal pain for 3 days. She localizes the pain to right upper quadrant, and she's also been having high-grade intermittent fever for 1 day and also had nausea. So when you take history for a surgical patient, let them vent out a little bit before you go for leading questions, because they'll normally give it out in the first few minutes. And then after that, go with your leading questions, because leading questions can often be misleading. So let them say. So right now, she's got right hypochondrial pain. She's been having pain for 3 days. So let them talk a little bit more. What else in the history? She says she's been having postprandial right upper abdominal pain for a few years now, has not had jaundice, apparently had an abdominal ultrasound 1 year ago, told to have gallstones. So we have the history right here. We have the diagnosis right here. So she's a diabetic with cholecystitis. Okay. So we have it before we even examined her. So vitals, please start with the vitals always. Before I look at the abdomen, I always look at the vitals. So pulse was 120, BP 130 by 90, saturation 96, RB is 400, and respiratory rate was 40. Abdomen examination, soft abdomen with a tender right hypochondrial mass. We know what the mass is. Mass moving with respiration. We are clear about what it is already. So what else to be done here? So we know it's acute cholecystitis. Probably has a mucosal gallbladder, palpable gallbladder there. And what else would you do? Would you give crystalloids? Yes, give crystalloids. Would you give insulin? RBS is 400. Generally, we jump and give insulin. Please note that her respiratory rate is 40. She may be having acidotic breathing. It may be diabetic ketoacidosis. So get an ABG. Make sure she's not in DKA. Then look at her potassium. Make sure she's not hypokalemic before you give insulin. These things can be killers. When you approach a patient with surgery who's especially sick, don't stick to the abdomen. Don't look at what you have to remove. Look at the entire picture. Why the tension? Tension because she's a diabetic in DKA with cholecystitis. These patients are different from a young man or a young woman. No comorbid illnesses with cholecystitis, which we normally manage non-operatively. So she was taken up for a cholecystectomy emergency. There's a pyocele gallbladder filled with pus and an emphysematous wall, and she had a stone impacted the Hartmann's. Okay. So there's another case scenario now. There's more to this story. If we have time at the end, I'll talk about it. But I want to get a few things across to you before we talk about the entire story. So Mr. Z, 65-year-old gentleman, has been admitted with us for lap appendicectomy 6 weeks after his acute episode. What do you think he would have presented with 6 weeks ago? I've already given you the answer. He would have presented with acute appendicitis. Basically, I'm trying to ask you what clinches the diagnosis, what takes you there to acute appendicitis. Right iliac fossa pain is something that you commonly see. So there's an Alvarado score. Dr. Alvarado in the 1950s came up with the score. It's tried and tested, and then there have been a lot of studies. And we know now that it's a useful scoring system and a useful clinical tool to rule out appendicitis. Ruling in is again something different, but to quickly rule out somebody with appendicitis is a very useful score. So these, I'm not going to go into the score, you can look at it later. So 1 to 4, you can send them off or make sure it's not something else, it's not appendicitis. 4 to 7, that middle area is somewhere where you would use your God-given judgment and imaging as indicated. And 7 to 10, you can go ahead with surgery. During my surgical training, if somebody came with the mantles of 8 to 9, we would go ahead with surgery without even doing imaging. But again, this changes depending on the surgeon and the setup that you're in. Okay, so he underwent a lap appendicectomy. Intra there was a retrocecal appendix, required mobilization for cecum. The tip was going into the retroperitoneum. We did an appendicectomy. To note also, he had an appendiculolith. There's more to this story, but we'll get back at it at the end. Okay, so other things are, how will you manage an appendicular mass? Is it the same as appendicitis? Well, not really. The presentation may be similar, but when you examine him, if I examine a patient with appendicitis and he has a mass, I would be reluctant to operate and I would try not to. What we do with appendicular masses is we treat them non-operatively. We don't like the word conservative, feels like we're doing something less. Non-operative is a good word to say. So we use the Oshner-Sharon regime, which is essentially we monitor the patient, give him bowel rest, IV fluids, analgesics, anti-inflammatories, mark the mass, look for fever, tachycardia, these things. And if he passes Oshner-Sharon regime, slowly start him orally and then plan an interval appendicectomy. Why not go in right then? An appendicular mass is made up of small bowel and other bowel clumped together and some momentum. So if you go in, try to do an appendicectomy, a lot of chance that you'll cause other injuries and create a bigger mess. Mass versus abscess. Commonly, you may see an abscess also, like a mass. You present a little more sicker, high grade spiking fever, very tender, and imaging will help you clinch the diagnosis. But mass versus abscess, you can clinically differentiate too. A mass has bowel has air, so air will be resonant on percussion. Abscess has pus is fluid. Pus will have dullness on percussion. An abscess would be drained extraperitoneally or through an image guided drain. Mass you would try to non-operatively manage and then do an interval lap appendectomy. बच्चा रोता है, बच्चा सोता है. This is something, if you read Park, you would already know what the diagnosis is. Master A, 7-month-old baby, presented with incessant cry for one day, multiple episodes of bilious vomiting and red currant jelly stools. I know that you guys are already know the diagnosis. He's been having episodic pain that's been resolving spontaneously. That's why bacha rota hai, sota hai. So at this point, we already know this is going to be intussusception. Vitals. I want to emphasize the importance of vitals when you check a patient. Before looking at the abdomen, always look at the vitals. Pulse 150, capillary refill 5 seconds, moderate dehydration, febrile 104. Abdomen, palpable mass in the LIF and empty RIF. So management for this, CBC, electrolytes, IV fluids, IV antibiotics, imaging options. I didn't even go for imaging for this. I already knew what it was. We went straight for surgery considering how sick the child is. But imaging options always useful when you have a doubt. Ultrasound can show a donut sign, X-ray may show obstructive features, CT a sandwich sign. You can look up these signs later. Usually intussusception, it's telescoping of one part of bowel into the rest. The proximal bowel generally has a lead point, a pathological lead point. Sometimes it can be a Meckel's diverticulum, a polyp, Peyer's patch hypertrophy, and then this, due to peristalsis, will telescope into the distal part. Although studies have shown that pathologically only 10% had pathological lead points, but we always believe there's some lead point causing it. Diagnosis is key. Also make note of the age and the symptom complex. This 7-month-old child, it's around the time when they start weaning, and there's shown to be an increased incidence of intussusception around this age. Also, rotaviral infections, they'll have cough, cold, fever, some loose stools. After that, you have lymphoids, which are rich in the Peyer's patches. They hypertrophy, act as a lead point, and then you intussuscept. So, after resuscitation, we took him for an explanatory laparotomy. What had happened here is his ileum had intussuscepted in the cecum. Cecum had gone up into the transverse colon, then descending colon, and he had a mass in the left descending colon. That's why his right iliac fossa was empty. So as you can see here, this is not the first picture. I started reducing the patient. This is the colon here. This is transverse at this point, and this is the small bowel that I'm trying to pull out and reduce. So and then at the end of my reduction, I noticed that most of the small bowel came back to good color, but the ascending colon, areas of it were patchy, gangrenous, and they were perforations. So in a stable patient who's not peritonitic, more often in bigger centers, what they would do is they would do a barium contrast enema that would also get your diagnosis, and hydrostatic dissection, give a little bit more hydrostatic force by lifting the barium solution which you're infusing rectally. That will help reduce the intussusception. So this child obviously was peritonitic and febrile, so he had perforated, so we had to take her for a laparotomy. So this child, we ended up doing a formal right hemicolectomy and then bringing out stomas. Believe me, the baby cried, the mama cried, we also cried, because dealing with stomas in a child is again a nightmare. Ileostomies, if you remember your surgery posting, ileostomies, we try to bring it out and pout it out because the contents of the ileum are very erosive and they erode the skin off. and then we put a tight fitting stoma bag. But the colon is not like that. The colon contents are more solid, they don't irritate as much. So in a child, you can't obviously put a stoma bag, and it's a nightmare. So it just skin excoriations were a nightmare. And a child had loose stools, we would all cry again. So we reversed this child later, after a month, and then he's done quite well. Mama's been nice enough to send us pictures, and she's been happy that we can share her son's pictures for you guys to learn. So, not getting more into that. So, slightly pregnant. As surgeons, we like to deal in absolutes, and generally there's a dichotomy to a management. We either operate or we don't operate. Slightly pregnant is something interesting, a story that I want to tell you. Mrs. B, unmarried 20-year-old lady, was referred from a local clinic with a suspicion of acute appendicitis. LMP 15 days prior to presentation. While I was examining, the boyfriend took me out and told, "See, she's thoda sa pregnant. हमने UPT किया था, थोड़ा सा पॉजिटिव आ गया. थोड़ा सा कैसे हो सकता है?" Anyway, so getting to vitals again, tachycardic, pallor present, diffusely tender, UPT strongly positive, empty endometrial cavity with free fluid in the pelvis. So this obviously it's a ruptured ectopic. Two white bore IV cannulas. Same time when you're taking the bloods, send for grouping and typing and cross match because you might need blood. We took her up for a diagnostic lab, proceed peritoneal lavage and a right salpingectomy. Intra-op we had 500 ml of blood, 500 ml of clots, and a right ruptured tubal ectopic. As you can see, this is the tube with the embryo and a bleeding area, which we have removed. Was pregnant. Taking the history is very important, and be sympathetic because we're not here to judge. We don't know what they're going through. We're here to treat. You can always offer your judgment and your remarks later. Better to be soft about it because they're coming to you with problems. Just being a little showing a little compassion goes a long way with helping the patient. So Mrs. C, 32-year-old lady, presented with severe abdominal pain, nausea one day. Probing history, she told she was pregnant, taken over the counter meds, went on to continue to have bleeding. Ultrasound on outside showed RPOC, retained products of conception, had a DNC at a lower clinic, then discharged. She came pulse rate of 140, BP by 100 by 70, very pale, abdomen distended, diffusely tender. We put on wide bore IV cannulas, took blood for cross match group and type, and then we took for an exploratory laparotomy. Prior to this, we did an ultrasound which showed moderate fluid in the peritoneum, which was probably blood. So, intro, this is what we found. We found uterine perforations. And initially, we started off as a fanal steel incision. We had to convert to midline to make sure there was no other vascular injuries or bowel injuries. And she went on to have a uneventful recovery. No gas. A lot of people come constipated to the casualty, but it's important that you differentiate constipation from intestinal obstruction. So this is Mr. D. He presented with 45-year-old gentleman, presented with history of constipation and for 4 days, associated with multiple episodes of bilious vomiting. Surgery is simple. We're not very smart. We just see what is there. Obviously, what is in the history. We know that we know that he's obstructed. But what else would you ask? Most common causes are adhesive intestinal obstruction. So ask for past history, past surgeries, past hernias or present hernia. Hernia is the second common cause. Other things to think about is malignancy. Depends on what sort of patient you get. Younger patient, you would think about malrotations, Meckel's diverticulum, vitreointestinal tract issues. Older patients, you would think about malignancy. Right colonic growths generally don't get obstructed. They have a ulcerative growth. They lose blood. Very chronic, indolent course, anemic, and then we find out that he has a growth. Left colonic growth, more dramatic, more like a ulceroproliferative growth, get obstructed quickly. So anything else in the history? Always good to get your medical history too. He was on ATT for pulmonary TB. So if he was on ATT for pulmonary TB, there's a good chance that he has abdominal TB if he's come obstructed. So examination, vitals. Again, start with the vitals. Dehydrated, tachycardic, BP borderline, abdomen at step ladder, pattern of small bowel that is visible, and a palpable severe RIF, severely tender RIF mass. So same thing. IV, white bore IV cannulas, did an X-ray, abdomen erect and supine, peritonitic, X-ray showed multiple air fluid levels, put an NG, put a UCAR, took him up for exploratory laparotomy. This is what we found inside. He had ileocecal TB. As you can see, these areas of green, this is impending rupture, gangrenous right colon, and you see the small bowel is filled with stools. It is quite obstructed. So we did a formal right hemicolectomy and then did a ileotransverse anastomosis. These are other X-rays, not this gentleman. Whenever you think there's someone who's obstructed, get an X-ray erect and supine of the abdomen. Okay, because supine X-ray will show you air fluid levels, which will tell you is obstructed. But a erect X-ray will show air fluid levels, telling you is obstructed. But a supine X-ray will show you the level of obstruction. If you can see here, this is centrally located bowel that you can see. There's complete rings over here. It's called valvulae convolutus. So this is jejunum. We know this is the level of the jejunum. Ileum will be more smoother, more to the right side, left side jejunum, more centrally located. Valvulae convolutus. So we know what we're dealing with before we even get in. So intestinal obstruction, if he's peritonitic or tender, we'd go directly for surgery. If he's not, then we would like to get some imaging. TB can cause everything but pregnancy. These past few years have taught me that it can cause everything. Yeah, but pregnancy. So tasty coins, foreign body injections, extremely common for young children. Follow the ABCs while assessing your airway, your breathing, your circulation. That's how you start. And do not attempt to remove foreign body in emergency. Believe me, it's so tempting. You'll see a tiny child with a little rajma piece just sticking out of the nose. Try to remove it. You may just breathe inside, and then you may make a foreign body nose into a foreign body bronchus. So see here, if you can see this X-ray, there's what appears to be a coin. Clinically, well, let's go to the radiology now that we've opened it up. How do you know it's in the, well, there's only two options. It's either in the airway or in the esophagus. The air, so if it's in the airway, the anterior posterior diameter is longer, so the coin would preferentially go like this. So you're not going to see the face of the coin in the trachea. Okay, and you can always get a lateral X-ray. The beautiful lateral X-ray is here. You see the airway is in front. Posteriorly, you have your esophagus, and there's a nice little coin sitting there. Cricoid esophagus, most common site. Cricoid esophagus, narrowest part of the digestive tract, and then later on, the other areas for it to get obstructed is pylorus, lower esophageal sphincter, LES, pylorus, IC junction. But most commonly, if you pass through the cricoid, you're usually good to go. Normally don't get obstructed. Other foreign bodies that you should be careful of is batteries. Batteries, we really don't want them passing through anywhere. It's going to erode and cause perforations. So this child, we intubated, passed a passed a scope beyond where the coin was, passed a Foley's along our scope, inflated the bulb, pulled up the coin, and discharged the baby 2 hours later. Differential for acute scrotum. If you find somebody with acute scrotum, please call a surgeon. It can be tricky. These are the few differentials I want to put across. Torsion testis, epididymoarthritis, Fournier's gangrene. Each one is extremely different from the next. Please call a surgeon to evaluate. So torsion testis, generally you see it in a 15 to 25-year-old younger man. The test severe pain, sudden onset. Testis, when you examine it, will be higher up in the scrotum, near the root of the scrotum. Sometimes you may even notice that the testis, instead of being the long pole like this, it may be horizontal. And yeah, you need to take him up for emergency surgery. Normally, a well-developed normal testis does not go into torsion. These ones that are, the undescended ones and the ones that are at the root, other problems can cause torsion. But whenever torsion is a surgical emergency, if you don't take it out, go for surgery within 6 hours, this is what's going to happen. So this child presented with torsion testis, obviously, came after 3 days, managed as orchitis somewhere else. We had to go and do an orchidectomy. Unfortunate, but it's really sad to do that, and it's really sad that it happens in younger children. We generally go ahead and do an orchidoplexy on the other side. The last 3 cases in the last year, 2 of them have ended up in orchidectomy. Only one have able to salvage. Epididymoarthritis, generally it's a retrograde infection, urethra infection, prostate, seminal vesicles, and a backflow into the testis. That's generally what happens. They'll have severe pain, swollen scrotum. Elevating the testis will reduce the pain. I think my time is up. Is my time
Yeah,
up?
you can just pass some remarks. I mean, concluding remarks, and we'll take in some questions from the
Yeah, I think
audience.
so.
Yeah.
The last thing I want to say is when to refer, how to refer. It is the rural dilemma. Let your seniors decide. Decision to refer depends on a lot of things. It depends on what are the services you can provide. It depends on what he needs, what is the best for the patient, the location of your center, and competence of your support staff. Like I can do the coolest surgery, but if I can't manage him post-op, I shouldn't be touching him at all. And how sick is your patient? Like I may want to refer a patient, but is he going to reach to the referral center? And at the same time, I want you to remember, referral doesn't mean you do substandard care. Okay, see, for example, this is a man who came with a road traffic accident, has a fractured dislocation of the ankle, and obviously he needs orthopedic care. Obviously I have to refer him, there's no option for it, but he has no pulse. Okay, so if I refer him like this, he's going to lose his limb. So what we did is quickly washed, gave antibiotics, reduced in casualty, put a slab, and then referred him. Okay, I think we're ready to take questions.
Right. I think wonderful last slide that uh, it's all about discipline combined with passion. And when you have passion, you will always chase knowledge, but more important to translate that knowledge into wisdom as such. So, if any of you have questions on surgical emergencies or want to share something, please put it in the chat box. So, they've referred in the group as such, and we recently had one case which was discussed in the group where a patient was diagnosed with appendicitis but was refusing treatment and took treatment for homeopathy and now has come with abdominal pain, dehydration, all that. So, what would you suggest in this instance?
So, if you have a diagnosis of appendicitis, the treatment's pretty clear. Like, if it's, I mean, you have two options. Either you do a appendectomy in the acute setting, or you wait, treat with analgesics and antibiotics, and do an interval appendectomy. So the other story which I wanted to say is I'll give you this example. Okay, this will help you clinch it. So this gentleman had appendicitis, and well, he presented to me with hip pain and emphysematous uh, infection of the thigh. So, so what I did was I opened up his thigh, did fasciotomies, and there was stool coming out of his thigh. Just imagine that.
Wow.
So, what he actually had was a retrocecal appendix that had ruptured into the psoas and then tracked down into the thigh. So, this is an example of a complicated appendicitis. There is a lot of times what happens is appendicitis just does subside well with just analgesics and antibiotics, but sometimes that's not the case. So, we ended up taking him to OT for 24 times,
My
debrided
gosh.
everything. Later on, went, didn't do it, touch his appendix at that point, dealt with this, then grafted him. Then he developed a hernia over the area where we had drained him, did an appendectomy, then converted, did the hernia also. So appendicitis can take a very different course. So if he's not willing, if somebody is not willing, you can't force anybody into anything. And a lot of times people go away from me also. So you can't, not willing, give him a course of antibiotics, tell them the risks which are there, tell him to come back when he has pain. And more often than not, when they come back, they'll come back. Either they'll, it's going to be two courses. Either they'll get better and go, or they'll come back peritonitic.
And what would you say is, again, I know it's a difficult question to answer because it varies from center to center. How can one pick up surgical skills during a rural practice? Because a lot of people have this mindset that I'm just post MBBS. Should I actually be doing these surgeries or should I be assisting someone in doing these surgeries? So, what would your sort of suggestion be with regard to how does one pick up surgical skills if someone is passionate about it, interested in it during rural practice?
Reading can only take you so far. Hopefully, the center that you have has a surgeon, and working under him will give you the most exposure that you can have. Like, I had come to Himachal wanted to do internal medicine, but my boss was a surgeon, and I operated with him multiple times. And towards the end of my bond, I was doing cesareans independently, assisting him on lap and open surgeries. And hopefully, you have a surgeon where you are. Without hands-on experience, it's difficult to get it. And there is a little danger with being a little brave when you don't have anybody with you. So, sorry, doctor, can you just show those slides again? I just wanted to show once. This, I guess, this would answer your question. So, see, we all know how to suture at the end of MBBS, but for example, these are something that I don't want you guys to suture. Like, this is a good example. Like anything in other places, locations can be sutured, and you may ask me why. Like, look at this, so benign looking, no, but it's over the extensor tendon, and if you look at it from the side, see, he's lost his ability to extend his finger. So the small things that you should be wary of, and use your common sense and discretion. And I hope you have a surgical surgeon where you're at. Hmm.
Yeah. Be circumspect. Let's not be very brave as such. But more importantly, if there is someone who is assisting, who is a trained surgeon, then nothing stops us from exploring the field. Well, thank you so much, Dr. Pradeep, for taking time off and such very beautiful stories. They always say nothing can teach better than stories, and such wonderful stories. And we look forward to having you again in our classes for the rural doctors, because someone serving out there in the field and no one better to share such experiences as such. Thank you so much.
Thank you, Dr. Nathan. Thank you. Thank you very much.
Right, so we come to the last session of the day, and this is going to be a very, very interactive session with the doctors from the batch of 2016 and 2015 from St. John's Medical College. We are happy to have Ronald Joseph, Tanmay, Mark, Queenie, Sandra, Reggie. Please switch on your uh, videos as such. So, first of all, I know that it's been few months for most of you from the batch of 2016, but sort of from and of course Ronald from 2015 as such. Um, just starting off you with Ronald, you're almost coming to the end of the bond. What is it that you have sort of learned so far, or is there something that you would like to say that yes, I entered bond thinking it was like this, and today when I'm sort of passing out, this is what I feel it is?
Sorry.
Yeah, Ronald, we can hear you, I think. Go ahead.
Yeah. Okay. I mean, the expectation I had from my bond, actually, I think was I've set a low standard because I expected a lot of things, but then going almost completing it now, I feel like it's superseded my expectations quite a bit, and I've learned in much more than I would have thought I would have experienced here. And it's not just from the entire medical aspect, but the orientation to rural health as an entire different aspect of medicine. Um, so, um, I don't know if I have enough time to go over the specifics of everything, but when I started off my bond, I came here without having an idea about the center. Like, I only knew from my seniors what the center was, but I never had the chance to come and visit it myself. But there's a long line of Johnites who've been coming here, and so I sort of landed in the middle of it. And then when I came here, to join is for the first time when I came to see the center and see rural medicine for what it really is. When I joined, the first week was actually I was like too stunned to realize that I would have to be doing this for the rest of the 2 years, because there was so much happening at the time, and then I wouldn't know how I'm going to be a part of that. How where I would fit in, how much of that would I have to take over? Because seeing my senior, luckily enough, like Dr. Pradeep said, it's when you have someone there, it is always easier for you and to help guide you. So I had one of my seniors here, and she sort of was able to give me a handover, orient me to how to sort of settle into things, manage my time well, and it's sort of like hand holding for the first 2 months of it, because that's where you are most confused and you will take time to adjust. Doesn't matter from here to a new place, even if with the experience I have, you will take that time to adjust, and the initial months are just going to be a bit difficult just for you to get the hang of things, because things might not be running as you expect. It will take a bit of adjustment for you to practice it there, and for the system to get used to how you are as well. So that initial few months is definitely crucial, because and you have to be a bit flexible. You may expect to do a lot of extravagant things, or you may be a bit overwhelmed as well. It can be either of the extremes, but so it's all about how you try to adjust into that setting, and then it'll sort of transition smoothly from there. So your guidance of your seniors is definitely very important, and so you might have the worry of the skills. So I definitely did. Like when I saw what was happening, I said, I've never done this. I don't know if I can do go ahead with it. But skill is something that you acquire through practice. It's not like you're going to wake up one day and suddenly be able to do everything. So you will definitely have to put your effort into it, and like once you keep repeatedly doing it, and especially so you make sure you don't do it wrong, and you try to improve, and every time you're doing it, and it's always helpful if you have someone there who's done it and who's there to by your side. And as that goes by, you acquire all these skills, even if it's just from seeing patients, the knack of how to go through your OPD with seeing your patients regularly, how not to miss out on things when you're seeing patients in the OPD, or from doing minor surgical procedures, or even doing major surgeries themselves or assisting in them. It's something that acquires through practice. So then initially it may be very overwhelming. You may feel like you do not fit in, but as time goes
So
by and
essentially, so
with
essentially,
good
it's more
effort.
of an adjustment phase which everyone goes through, and as you
Yeah.
go through the 2 years, it is going to be. Let me come to Tanmay and Mark, both of you, and speak. Moving out from St. John's, from the internship, from a very protected environment to being out there all alone. What have been the initial few months like? Yeah, Mark, you can sing out your answer too if you want, but
Okay.
go ahead and tell us.
Hello. Am I audible?
Yeah, you're audible.
Okay. Yeah. So, just with going into bond, I think that there were two categories of us, and I think there are always two categories of people in any activity. You either you think you're going in prepared or going in unprepared. But I absolutely agree with Ronald and what he said. I think everyone was utterly unprepared as to what met us when we joined our centers. So it's a whole different world out there from that protected environment we had back there in John's. In John's, our work consisted mainly of a lot of paperwork with the occasional clinical experience. But as over here, I still remember my first day when I had completed rounds. I felt okay, I'm protected because I had a senior here. Then immediately sister was like, okay, you go to OPD, you will manage OPD, And I was like, what? And yeah, so I was just directly thrust into it, and initially I was kind of shocked by that, but then I think that willingness and that readiness to learn from everything, that's what really helps you in bond. Treating everything as a learning opportunity and realizing that in some way or the other, Johns has sort of prepared us in to some extent in all of this, be it from the classes with which Dr. Chaitanya used to take, the Johnite Academics group, or just any this thing in our interactions with all the doctors we had in
I'll
Johns.
just come back to that point of yours about moving straight from internship to and how prepared you feel. Tanmay, your first reactions on the first few months.
I think it was very terrifying because in my center it's just me and I work in a mobile clinic, so it's just me and no one else at all. So it was very scary. I didn't have anyone I could talk to about my clinical decisions initially. Someone I could say get a second opinion. So and then I was always doubting myself, is this correct, but like Mark said, like the classes that Dr. Chaitanya and the others took really helped, and I kept going back to the notes that I've taken and to the slides they've shared to kind of make sure that I'm making the right decision every time. And for a lot of these patients, I know that other than me, other than my mobile clinic, they will not go anywhere. So they are entirely dependent on me, and so to do the best for them, I think it was very scary initially. It still is, but it's getting better.
Yeah, so I'll disagree with the fact that there is no one to share your clinical decisions with, because the Johnite Academic group is there, which none of you use to a large
In
extent.
person.
But coming to Queenie and Sandra, how prepared do you think internship made you to start your first few months in Bond? Do you think that whatever you saw in internship was enough, or do you still feel the same anxiety and nerves? We'll go with Sandra because she is nodding her head vigorously. We'll move with Sandra and then come to Queenie.
Definitely not. Because like Mark said, during our internship, mostly what we had to do was clerical work, run around, mark things on your whatever papers, fix appointments. We were hardly involved in the decision making process unless we actually showed interest. So for my first few months, it was both scary and enlightening. Scary because we usually get mixture of patients, pediatrics, mostly pediatrics. And pediatrics, I'm very apprehensive about them, to be honest, because in fact, I cross check my doses whenever I prescribe. And the thing is, they come with their parents, right? So like when you cross check the doses on your cell phone, they kind of leads to, they don't trust you. They look, because you're cross checking on your phone, you're checking on the internet. So it was kind of scary in the beginning, but now it's okay.
Right. Queenie?
Like Sandra said, it's been the same. Like during internship, obviously we were not prepared for anything that Bond had to do. But I was lucky that I had a senior here with me, and I basically just tagged along behind him. And Ronald's right here with us, and I would just do something, and then I would be with I would do anything with the confidence that even if I do something wrong, Ronald's going to come in the evening and correct it all and go back. But now with Ronald leaving, I don't know what's going to happen in the next few months.
No, I think it's a very, very important and valid point being brought about as to how much of internship is sort of geared towards practicing out there in the real world and what really institutes can do to change it. And the second most important thing is the sort of importance in having a senior out there to guide you and the center choices that you make with the presence of a senior and not. And really, should the institute sort of look at an overlap of at least 4 to 8 weeks to help new bonders to settle in? Reggie, where are you sort of right now in and as a bond center, and how important are resources to you, and do you find it very difficult to sort of approach and make the right clinical choice when you see something independently?
Right now, I'm working in Navchetana dispensary in Mandya. So resources, as in for me, I usually end up looking up in Google if I have a confusion. But thing is, Google gives you the only the extreme kind of diagnosis. So some simple things are always missed out, like the headache, some basic things. So when we look into it, it's just the extreme things which come up. So sometimes simple diagnosis of even sometimes even migraine, I think I probably will miss it. So it's something like that. I think resources wise, I think it's a little difficult because there's no senior doctor in my place. And also yeah, pretty much even PGs mostly, it's the daytime when I'm having my OPs. So I usually end up calling PGs, but if they're busy, even they can, pick the call and speak to.
Right. So what I sort of gather is, apart from the 2 points that we have sort of come out with, and we have Sister Sophia here from the batch of 2012, who is the Rural Outreach Secretary of the Alumni Association. And really, sort of as an alumni association, we are sort of trying to engage to find out what exactly is the need of those serving in the rural areas, and what exactly can we do as an alumni association, and what exactly can we convey to the from an institute perspective as such. So coming back to Ronald as such here, Roy, would you like to add in anything here at this point of time based on how it was during your time and your experience at CMC?
Thanks, Nitin. Nice to see you, Ronald and Queenie, and hi, everyone else. So I think the most important thing, it's quite upsetting, and as the Alumni Association, we should be a bit unhappy that we have a whole batch of interns telling us that they were not prepared during internship to take on the rural bond as such. And we as an institute stand for serving the outreach, serving the least of the population. It's time for us to actually reflect and see what really is going wrong. So from our times to now, what I gather is, I think there were a lot of faculty in Johns who had spent a significant time in rural hospitals themselves and were faculty in Johns at that point, who made sure that every case, every surgical case, every medical case, they would give you a outlook on, okay, if this patient was in a rural hospital, how would you manage? So that would always be the thing. And I think it's not just Johns. Even in CMC, we are having that crisis. That really that, the outlook of how would you manage a patient who's in a tertiary care in a rural hospital? How would you, even teach a batch of interns that? That's a big problem. So I think that as a faculty.
So Roy, just to sort of reflect back, it's I think about 8 years since you have passed out as an MBBS student. So it may be difficult to remember, but when you started your bond, did you feel inadequate and sort of not geared up to take on the challenge, or did you feel that internship was okay to sort of take on the challenges of rural bond?
I think by and large, to make clinical diagnosis and to know what you are looking at wasn't a problem, even when there
Okay.
was something like unusual, like trauma and things like that. Um, yeah, and
So
also
you
in
say
those 8 years ago,
so you have
the
some.
internet wasn't good.
Yeah, so from what I gather and even from what I remember, very clearly is post internship, I was sort of more or less confident enough to make a diagnosis. Sort of with the management part, we are still sort of shaky post internship. Is that the sense still, or is that still
Absolutely.
challenging to make a diagnosis? Mark, Tanmay, Queenie, anyone who wants to, Ronald, anyone who wants to take it.
I think
So
definitely
I feel like,
making
yeah,
diagnosis is something that the Johns has equipped us with
absolutely.
adequately. It's just I think the treatment part and the managing part it's still a bit scary for us.
Scary
We
for us.
still feel
So
anxious.
we have Dr. Anthony Robert here, president of the Alumni Association. He's joining in from another conference that he has been an expert panel member on. So just to sort of recapitulate the discussion that we have had so far, the sense that we have got is that internship still tends to be clerical, and people feel in their initial few months of the rural service that they are not equipped enough to handle. B, not having any senior or sort of guiding force in the rural center makes a big difference. So we had Queenie here who had Ronald sort of guiding her, whereas in a few other situations, people are alone and they find it difficult and they still have to resort to Google, which may not be the best resource, or trying to call postgraduates as such. How do you think, as the Alumni Association, we can engage, apart from, of course, the CME and the Johnite WhatsApp academic group? How do you think, or is there something that the institute can reflect on to make this better?
Yeah. Firstly, the fact that you feel when you're out there, first of all, hi to everyone from the Alumni Association. The fact that you feel that, okay, I need some guidance there, because sometimes the danger is after an internship, you say, I'm the king of everything and I can do it. If all of you felt that way, then I would be more worried. The fact that the little anxiety is there is actually a sign of integrity and of the need to bond together. So I think how we can help is before I even go there, from what I've spoken to some of the bonders, some of the centers that I've spoken with, I think loneliness, not just in terms of making a clinical decision, but loneliness is the first time you guys are out on your own with no one to like an umbrella there, and that I think is something that we need to address. That is something that we've discussed, and I think apart from the WhatsApp groups which Gino Joy and Nitin and all have set up, and occasional ones like this, I think we need to have an active hotline. We should have some reach out number where someone can tap in, and then that person can put them in touch with whoever can guide them. This is for the clinical, but I think more than clinical, from the alumni, I think we need to make more to be in touch with them either on a virtual basis, or I'm insisting that all my committee members at least visit one center in that year, so at least we're able to reach out to someone. Mainly our children should know that yes, there is someone who'll reach out for us. I cannot speak for the institution, as you know that, but I think from the alumni we will do whatever we can to try and increase communication, and I'll work with Nitin and Prithvi on this. Keep going. Yeah.
Yeah. So, Ronald, coming back to you, would you like to recount any one incident which was the defining point of your rural service?
Um, so, I mean, there have been many things over the last 2 years, but one of the ones which I frequently think back on is I was doing duty one night, and there was this patient who came in with abdominal pain. So it was just a routine practice to do things, and after I would have never expected myself to be able to manage that, but then after the end of it, this is why I still remember it till now, is because in the middle of the night I had a patient who came in with severe abdominal pain, a young female, 24-year-old, and who was just in severe distress. And when she came, she was very drowsy, not responsive, and so I had gone examined her. She was tachycardic. She had severe lower abdominal tenderness in the right lower quadrant. So at that time, we did not have an in-house obstetrician. So I also there was no surgeon available at the time as well, so it was just me on call. And but because I've been trained by them and I've been seeing them, I just did the routine work. I resuscitated her. I sat by her the almost for 2 hours, rushing IV fluids. Her BP kept dropping below. She was going into hypertension. I just stood by the bedside, like rushing fluids into her to maintain the blood pressure. Put her on a O2, and then so had an ultrasound machine, a portable ultrasound machine, which I brought by to the bed, and then I did a scan of the abdomen. So there was um, uh, there was a bleeding which I could make out, and a small gestational sac I could see. So it was I suspected a ruptured ectopic. I had to arrange for that patient, knowing where my referral centers are, and which would be the nearest. So the center which could provide care the most, I would be about 4.5 hours away. But there was another upcoming medical college with an obstetrician, so I had to call up that place that was about an hour away. So I had to call them up, speak to the obstetrician myself, try to figure out how to refer this patient, stabilize this patient, and luckily we have a blood bank. So I started her on transfusion, and so he also was very apprehensive since he was a postgraduate there who was just posted there, and he also was apprehensive. So it was trying to coordinate whether, because this patient would definitely not make it 4 hours to another center away. So trying to refer this patient and under stable conditions. So she made it to the hospital there. She was still hypotensive, but they were able to operate her, and they did a self-injectomy, and she came back to the OPD like about after her discharge to about 2 months later. And then I still saw her and remembered her, and then I felt very happy because I saved the life of that patient, and it was just a
that,
nice
that
experience.
feeling of gratification is something
Yeah.
completely different. So, Queenie, Sandra, and Reggie, I mean, if you could sort of take turns and answer, what do you see the next 2 years of rural service being like, and what are your expectations as such? Sandra, if you could start with you.
Yeah.
Yeah.
What I expect is to gain more confidence, both in diagnosing and in administering the right dosage, and probably improve on my soft skills. Yeah, that's pretty
Yeah.
much it.
Queenie?
Um, by the end of 2 months, 2 years, I hope that I'd finally figure out what I want to do as a post graduation, as well as currently I like surgical specialties, so I get a lot of chances here to practice on those skills. So I'm happy that at least by the end of 2 years, my skills would be a bit better than what it was during internship, and of course, handling cases and being better with management by the end of the 2 years.
I think that's a very wonderful point that you brought out, that essentially rural service can be the time you get to sort of know yourself more and make clinical choices as to which clinical field or even non-clinical field you want to pursue. Reggie?
Uh, actually, by the end of 2 years, like I just wanted to be able to, convey to the patients. Like it's actually what I figured out is more than the medical treatment which we give. It's basically the advice that we give to the patient, and that is what they actually, which gives them the like when they have to come for follow up or things like that. That how many days will it take for them to, kind of have their symptoms down. So
Okay.
basically, I just wanted to have a grip on, giving a very good education to the patient, like to convey that, this is how much time it will take to,
So essentially,
actually get in touch
patient
with the patient.
communication skills and awareness as such, which is a perfect follow-up question for Tanmay and Mark, because you guys have been members of the committee also, and we all know that being members of student committee, you need good communication skills and all that. So, do you really think that in internship per se, just the daunt of clerical work provides you less time of interaction and communication with patients? Or do you feel, and I want a very honest answer, that somewhere down the line, interns and students of the current batches probably are not spending enough time with patients and probably want to go study for NEET PG? Do you think that the sort of sword of NEET PG is always dangling over even when you're doing internship, which sort of prevents you from spending more time?
I think there's some truth in both of the statements. because definitely there is time to spend enough, or there is enough time to spend with patients, even with no matter how much clerical work you have to do. But at the same time, sometimes when you post double duty and like you have some 40 orders to write, you're not going to go talk to a patient, you're just so tired. But but definitely there are a lot of opportunities in the hospital to go interact with patients, to learn more. It's definitely there.
Mark?
Yeah, I absolutely agree with Tani. So there were definitely adequate opportunities throughout internship, and I think I found myself in terms of my interaction skills. I think just again out of being used to talking to people through committee, I enjoyed talking to people, and I mean that definitely has helped me even throughout bond. So you do have plenty of opportunities to interact with patients throughout internship. There, however, I do feel that the tremendousness in terms of the paperwork does tend to dilute that. And since you end up being so involved with all of that, then you tend to have a little less time to do it. And if you want to interact with patients, it's something you choose to do out of your own free time. And I mean, yeah, coming to your point regarding NEET PG, I feel that nowadays, given the way medical education is conveyed out to newer and newer UG aspirants, people feel that like the moment they enter their first year, they should start their preparation from that point. And I've even had people ask me which platform I should join when they were in first year, when I think I haven't decided what platform I want to join right now. And yeah,
Yes, so very varied perspectives and things which keep changing as such. Ronald, coming to you, what would your advice be to rural doctors who, I mean, the batch who is doing their first year of rural service as such? What is, very briefly and crisply, 3 points that they should keep in mind in their first year? And especially to Queenie, who's getting worried now that you're leaving as such.
Um, okay, so 3 points in. So one is that things you're going to learn is definitely going to come more out of your practice, and that's how you're going to develop on your skills and become better as a clinician or as whatever you're a surgeon. All your skills develop only from seeing your patients. So you should never miss the chance of and the opportunities provided to you in seeing the how many of our patients come to you, and so always try to see them to the fullest. So even if you think it's something that it's that probably to be seen by a specialist, just make sure you put the effort to see them thoroughly and to look back and read upon all these things, so that the next time someone does present, you would know a little more than what you know the last time. So that is you have to put that effort in, and otherwise your bond experience is just going to be like you come in, you do things you know to do, and then you go out. So you don't have much of learning there. um, Another couple of points is that again, remember your care for your patients is your even though you have to learn, you also have to look at what is best for your patients. And you if some things are just out of your hand and you have to push your patients, even though you are in rural centers. For some things that are better for patient care and you think it can be done better, it's always to better to refer them rather than keep them. And if you're in doubt, if you are providing the wrong line of treatment, you may not know till it becomes too late for them, and it's the patient's lives that you are that's in your hands. So if you're ever in doubt, it's okay to refer a patient. It's okay to ask for help, and you have to be always willing to ask help, no matter how much you think you know, how much you do. It's you have to be willing to recognize when you are not able to do something, and when you have to refer them, and when you have to seek help from your seniors, whether consulting them online or if they are there with you. So knowing where your boundaries are is important. So I think these would be the main 2 points. That one is you're only going to develop with repeated practice, and the other thing is it's okay to not know things and to know your own limitations.
Yeah, so one point which Sandra brought about was sort of looking at the phone and trying to look for resources in front of patients. Now, sort of in the alumni Christmas meet, I met a few of your batchmates and people, and they said that's probably one of the reason the Johnite Bonders group is not that active, because people seem to think that when you sort of use the phone in front of patients, they seem to think lowly of you. Is that sort of the general perception amongst all of you, Queenie, Reggie?
Yeah, I think obviously patients, if they, I mean, when we're talking to them and we are looking at our phones and then what to do next, I mean, if they see the doubt on our face, and I feel obviously even they won't have the confidence in the doctor. That's what I feel. Although that's true, like the patient will not be confident, but if looking at the phone gives me a chance to provide a better care to the patient, I don't mind doing it. And in my experience, I feel tribal patients have been more understanding and more cooperative than non-tribal, so they usually don't mind or judge anybody for like looking at their phone and then answering anything.
Yeah, so my sort of take on this, and that's a discussion we would be having with the other 2014 and 2015 bonders from their experience, was that if you're sort of open to communicating with them that, hey, look, I am asking for help from experts who are in the city, and I hope to provide expert opinion and care, whatever the expert opinion is there, I would hope to provide you that. That's sort of been the perspective of some of the senior batches, that it actually helps when you're open to them rather than being doubtful, that yes, you're open to seeking help, you are open to asking suggestion and advice, and like Queenie said, sort of saying that you are giving better care to them at the end of the day. I think again it just comes down to the communication aspect as such. So how easy is it, do you find, to find help? Reggie already mentioned that he calls few PGs, but if they're not picking up the phone, it becomes difficult. Tanmay, Mark, any situation when you have had to call for help, and how easily has it been accessible? Sandra, if you can come into. Sandra, if you can start.
Thing is, I have two sister dogs at my center. They're from the batches of 2001 and 2004, so they alternate on calls. So I try as much not to call them because I wouldn't want to disturb them in the middle of the night. In case they don't pick up, I try calling PGs, and if they don't, I just figure out something and pray that nothing happens to the patient.
All right, and still not use the WhatsApp group. Okay, fine. We come to Mark. Yeah.
Okay, so at our center we have a couple of visiting doctors who come from Father Muller's. So I'm just outside Mangalore. So they've shared their numbers with us, and they are pretty much available most of the time. In case I'm unable to consult them in cases of that, then usually, and that will happen more during the night time. Then I think the PGs are usually fairly free. So I haven't faced too much difficulty in that regard in particular.
All right, Tanmay.
Most of the time, the patients I get are non-urgent cases. So I usually talk to them. If I'm doubtful of anything, I tell them, could you wait for some time? I'd like to speak to the specialist in this field, and I'll get you back. And I'll try to call them, and I'll just make them wait. And usually, most of the time, people, John's doctors have been very helpful. Even the senior staff, like if you message them, they do reply.
Okay, and how many of you manage inpatients also, like apart from OP? I mean, all of you have inpatients? Okay, so Reggie says that he doesn't have inpatients as such. So probably again the sort of setting that you are in also matters a lot as to how and when you seek help as such. So I mean, sort of to put it out there, and we always say it, and I've been saying it on the group as such, and even before being part of the alumni association, this was a group we formed in 2013, and it doesn't matter what time of the day or night is, someone would be there in the group always answering. Most of the times it's me trying to connect people across to different specialities. We also have Royson who takes care of trying to answer surgical specialities. Roy, what would your take be on what would be the best resources to take during challenging situations in the rural area?
Yeah, I guess there is no right answer to it, because there will be some people that you generally are used to calling and things like that. So those people may be approachable. But I highly recommend the Johnite academic group, because that's something I remember during our time.
I'm not
Every
paid
day
him, by
there
the
would be
way, to
something.
promote it, but yeah.
Yeah, I'll take it. I'll take the money later, Nitin. You can send it to my account. No, I would like. I think one thing is you. There are two things here. One is you like Nitin mentioned that someone will be awake, some PG will be awake, and some faculty will be awake. That's one thing. Other thing is someone. If you guys keep asking questions, you would have seen that someone in your batch would have asked that question, and then you are like, oh, okay, it's 2 a.m., but someone already had a similar patient, and these were the advices that were given. So, although there may not be anyone for you to contact at that point, you kind of know probably what you're dealing with. So, I think I would highly recommend using this group so that you have more people who've worked in such scenarios answer and at least manage that crisis, Nitin.
Yeah, no, so I feel that Dr. Robert spoke about the loneliness part and the sort of being alone on that. And I'm not saying that the group is a replacement for that. But what I remember over the last 10 years is there's a case for which we might actually not have been able to help, but that case would have been discussed. And later on, when it happens, someone else benefits from that. So that's essentially the whole point of sharing it, even if you don't have a patient there, that it ultimately entails the group at large. Last question to all of you: what do you expect from the alumni association moving forward? I think Ronald would sort of tell what he would have expected because he's finishing, but what would you expect from the alumni association moving forward to help you or facilitate you in the next 2 years? Ronald, if you want to start, how do you think we could help and we could help the connect being better? And we'll move Ronald, Tanmay, Sandra, Queenie, Mark, Reggie.
So yeah, so like the preparedness part, which most of them spoke on, I'm not sure if the alumni, like Dr. Robert said, whether the management itself can be a part of helping them, but they're definitely putting more emphasis, at least before the rural bond, before the bond, whether we start uh, between that time when we finish our internship and start sort of like a bridge between what we would face and some basic sort of skills that we might need. And so if this session sort of happens where people know where their communications are before they start the bond, they might be more open to communicate and tell what their problems are, especially where there are no seniors and they don't have any guidance. So there, before we start, if this can be, there can be a session for all those going to start the
So
bond.
essentially a bridge program. Once, and I probably think it is worthwhile doing it once you have selected your center,
Yeah.
been there it, and we sort of get a feedback, then probably creating a tailored bridge session for that would probably be a valuable suggestion. Tanmay?
Like Ronald said, definitely the bridge session would be really helpful. And Dr. Anthony was also talking about having a helpline. I think that would be a really great idea if it's possible, because just knowing that there's always someone to call and someone will be on the other end to pick up and help. So
Right. So a helpline from our side, which we would work on, sort of an official helpline, like I again mentioned. At least people like I can sort of speak personally for myself. People like Roy, Dr. Robert, Dr. Prithvi, and all. We are always there to help, and do not hesitate to call. Of course, I don't want to keep getting calls from Mark. That's a different issue altogether. I've been bugged enough by him. But yeah, I mean, on a more serious note, we will work on sort of an official helpline as such. Sandra?
In addition to what Tanmay said, I wouldn't want you guys to be judgmental of us because some of us have very stupid doubts. In fact, some
Yes.
of my friends.
Yes, so
some of my
that's the point I keep making, that I learn a lot from you people. And trust me when I say this, when you go into a super specialty field, you start forgetting some of your basic medicine. And the only way I remain in touch with medicine is because of the doctor serving in rural areas. It helps me revise how to treat hypokalemia, hyponatremia. It helps me revise how to learn ECGs. I have forgotten ECGs. I'm making a frank admission online on a live broadcast. So I learn as much as you people. And that is what I want. I don't know how, there are about 40 of you watching this right now. And I hope you spread this message among the WhatsApp group. We are not judgmental, and we all learn. People like Dr. Anil Abraham learns when we discuss things, and all of us over the last 10 years have got so used to learning from the group, because someone or the other keeps putting up stuff. So please feel free to ask the most stupidest doubt. Like, even for example, if you want to ask how to check the pulse, please ask, right? Because it's a good revision for everyone out there. So we are never ever judgmental. That is one thing I can 200% assure you. It's more not a more a reflection of you, but it's a good opportunity for all of us to reflect back on how better the training can be. I always believe that apart from the odd disinterested person who would probably not have attended anything, it's more a reflection on how training can be improved as such. So please fire away and please share your experiences. Forget about asking doubts and questions, but please share any experience you have. Because I remember there was a rural service person from Assam who shared quite a bit of medical legal issues also, and the difficult situation they were in. And we are all here to support you, discuss, and more importantly, I keep telling you, we are not here to teach you. We are here actually to learn from all of you. Yeah, Queenie.
Oh, I don't know how much this is possible or how much the alumni can help with it, but given that all the alumni have done the bond, I feel it would be better if there's a senior and a junior from the same college in a bond center with enough workload so that there's somebody to guide you and you don't feel like lost the minute you join. Because a lot of my friends are doing bond and they always keep complaining that there's nobody to guide them. So I feel having a senior and a junior at the same bond center would be a really good thing because most of the bond centers have enough work, and because of the work, they end up hiring doctors from outside, like junior doctors from outside. So if two people from the same college can be there, it would be better. And given that we are 150, there is the students are actually suffering with like finding a bond center. So like it could be helpful if there could be two
Yes.
people instead.
Yes. So again, like I said, very limited that the alumni association can do something on this front, but it's definitely a concern that we can put forward. And again, I'm speaking very personally, and an idea just which came across. If there's any alumni who is sort of willing to uh, train or be a mentor, an alumni who has done rural service and who's willing to be sort of a point of contact, I think we should approach and reach out to such alumni and tag them with June. And it need not just be for academics; it can just be for career, just like the mentorship system. I think it's very important that people who are in rural service, the mentorship system continues either from faculty in college or alumni who are out there who are interested and willing to give the time. We'll come to Mark in the end. I don't want to listen to him yet. Reggie?
Sir, actually, I'm not sure if alumni can directly do anything about this, but what I feel is all throughout my MBBS, I've been a Singi doctor. So basically, I do only the repeated questions in the exam. And what it covers is just the history, examination part, the diagnosis, and the treatment. So what we usually miss out on is, and even I think even during classes, what we usually miss out on is that once the treatment is started, like for how long, no, about the review, like for how long should the patient take, how long does the response take to kick in, and usually people just come and tell me that I've been taking medicine since 3 days, 4 days. Why is my cough not coming down? What am I supposed to do? And they keep asking, and then I really don't have a clue that okay, I start a treatment. How long does it take for the patient symptoms to actually come down, and how long does it take for the response? And also, there's been a lot of cases where like I get a lot of cases, especially of tinea. And what I've noticed is a lot of doctors miss out on a part that tinea, what I feel is personally that 40% is basically medical and 60% it's basically lifestyle changes. So they have to, maintain their hygiene and things like that. So the moment we, emphasize more on the education, what we give the patient, I think it'll make a little more difference. And I think in college, more we emphasized on the medical part of the management rather than the education which we give to the patient.
No, I completely agree with that. And I think one wonderful resource for doing with this, like you clearly said, you're giving treatment for cough and it's not coming down. What do you next is to look at guidelines, is to revise guidelines which are available, which clearly give a very beautiful flow chart and algorithms. Let's take, for example, BP. Do you start with one drug, two drugs? When do you escalate? When do you monitor for the side effects? When do you call the patient back? And these are some things that can really be discussed. And again, that's an idea which is for your batch to execute and implement if you people are interested, which is once in 2 months, which I would be willing to facilitate based on time, or someone from the alumni would be willing to facilitate. Give us three topics from amongst yourself. Like he said, tinea, someone would probably say hypertension, and we will go through the guidelines of that and sort of make it clear. And we can do it every 2 months once or 3 months once, apart from these big seminars, because in big seminars, sometimes the messages get diluted, or sometimes the core issues get lost as such. So give us three topics, and we will go through 15 minutes, just quick 15 minutes on the practical solutions for that in guidelines. And probably, your batch could create a rural doctor's manual as such based on those discussions. I think that's something for your batch to sort of explore, and which we would be happy to facilitate. We'll give the last word to Mark, who has been staying silent after a long time for a significant time. Go ahead, Mark.
Good evening, Jam Master.
Yeah.
So, no, so my expectation is sort of along the lines of what you said. So now my expectation is sort of an observation and expectation merged into one. So one thing is, I feel like the reason why my batch in general has sort of been very reluctant to interact with the alumni is because I've noticed a lot of the my batch, apart from the few of us that have repeatedly begged out for money during committee shift, we haven't really got a chance to interact with the alumni because of the fact that we missed out on the official that alumni lunch when we joined the alumni. So since we missed out on that, a lot of us really don't know the alumni. Now, the way I feel that what you had suggested, having a slightly more informal sessions where we discuss like the particular topics which are of interest in our respective centers, will also allow us to realize that we are a part of something. So one thing which I was happy about with regards to this session, it reminded me that okay, I'm a part of St. John's. I have this institution to fall back on should I have any doubt. And I feel like that's something that's lacking in a lot of centers, which results in loneliness, which results in not being confident in taking certain clinical decisions once in a while. So I feel like having these informal sessions would both help tackle loneliness in one end, knowing that there's someone is there, and also help us to get to know the alumni a little more. So I feel like that would definitely be
I
worthwhile.
can, on a lighter note, I can see the hidden request for a free lunch session, but that is something that I would inform. No, but no, no. But on a more serious note, I think that's a very, very valid point that you have not interacted with. Quite a few members of the alumni association and the alumni, and you sort of feel that there is an age gap, or you are not comfortable in interacting with the group, and we will see what can be done. One thing that we are sort of working on and looking to host is probably having a 2-day session for all the rural doctors on campus sometime soon, and that's a thought process which is going on. Whether you'll get lunch or not, I am not sure, but at least the academic program would happen, and we are working on it. There are talks going, and it should happen in the early months of the coming year, so not far away. So we are working on that, and yes, I think it's very wonderful to get these insights as such, and we just hope that you keep interacting with us, and at least through some of us, and whom you have bugged lot, not for money, but just simple reasons like that judge backed out, come and judge sort of thing, without giving that Suksaga chat. But yeah, I would say that try to reach out through us. People are there to help. People are more than willing to help, and people want to help, because again, we are not helping you for the sake of helping you. We genuinely are learning a lot, and it's impacting our clinical skills too, by realizing the really resource constrained setting that you folks are in. I'm pretty sure we are going to get more information from those who have finished their 2 years of bond, like 2014 batch representatives are joining us tomorrow, and also a few from 2015 are joining. We are going to have some sister doctors also to join in, and Sophia is writing down all the notes to present in the next minutes of the meeting possible. And Sophia, you want to say anything? You're mute. 1 minute. Let me unmute you. Yeah. Go ahead. Go ahead.
I would like to say something that what they are telling, I really understand the struggle. But I think Nitin, I have disturbed a lot in the middle of the night, asking for a help when I was working as a the bond center, and our professors also really they helped a lot. Anytime we can call, because maximum time I have done the night duties. So during the bond time, we had a real bond of with the Johnites Association to help out also that study thing. What I feel is when you come for mid bonders meeting, no need to say bonders. I don't like to use that word bonders. Rural service doctors. Okay, we are not the bonders. We are rural service doctors. Okay, so when we come for that mid meet, you can propose that to have a WhatsApp group with among you, because one thing I also felt many times, whether am I asking stupid question in the big forum, but we'll have a lot of answers from our seniors telling that different ways of guiding. I still remember that the coin when the child was swallowed, and then I would like to know which area it is, how many days it will take to come out, so that I can, whether I can admit the patient or discharge the patient. Over the night, our own alumni academic helped me in that how to proceed like that. So I am thankful of that, and we can help you out also. We'll put it in our forum. I have made a few notes of what you have told already, that when we come together also, we can make it a point to how to help from each experts to have one person. Sometimes it will be confusing that when many are giving ideas and their opinions. So that can be also be supportive.
Yeah.
That's what I feel.
Right. So thank you all so much for joining on a Saturday evening, pre-football World Cup final. And here's hoping, and thank you all for choosing to do rural service. It's not an easy choice to make, as I know, and it's really, I'm sure that even if the institutes or people do not express it enough, I think we all need to acknowledge that fact and be grateful of anyone, whether it's as part of the bond or not as part of the bond, anyone doing a service to the community, and that's something we need to be thankful of. Right. So thank you all so much, and hope to see you tomorrow from 9 a.m. as we start off the last session of the day. We are going in with approach to pediatric seizures, surgical procedures in the OPD surgical procedures, busting toxicology myths, and I think there are a few more obstetrics. A lot of sister doctors asked for topics on obstetrics, so how to manage high risk obstetrics. And of course, we have Dr. Ravi Narayan, who will share journeys from the rural service in the 70s and 80s and how it really started. So thank you, Ronald, Tanmay, Sandra, Queenie, Reggie, and I don't know who else I have to thank. I must have missed out some person, but thank you, Mark, as well, for coming forward and sharing your experience, and hope to see you to be active. And for your batch, really, I know that over ICC, I have seen enough mad ads on the first batch of 150 students. But I really hope that the first batch of 150 students does make a significant change in the way rural service is done and leaves behind a legacy for the other batches to follow. Right. All right. Okay, then. Thanks a lot. See you tomorrow.
Thank you.
Thank you,
Thank you,
Nitin.
Nitin. Thank you. Thank you.
Thank
Thank
you.
you. Bye.
Thank you, Nathan.
Bye.